And I don't know, those of you who may have watched the interviews that I posted online that I did with some of the old osteopaths, Josephine Rockow worked with her, and I just found it very personal and very touching what she actually did way before anyone else was thinking of it. The work that she did with children with cerebral palsy, very groundbreaking for that time. So some of the things we'll see sound very matter of fact today, but it wasn't matter of fact in the 1940s. And actually, Beryl Arbuckle had a clinic which would have been not too far from where my house was. Of course, not that I would have known when I was a little booger, but the clinic that she treated children was right down the street from where I grew up.
So you were in the cranial field.
I was in fact in some field. You know, after I did that interview, afterwards, Beryl Arbuckle just started showing me all this memorabilia. You know that little thing? Those of you who have children, you put your kids in this little box that has wheels so they can run around, and then you can go play video games or do whatever, and you're still a good parent so they can still run around. Okay, she showed me a prototype for that was done in the 50s, that one of her cerebral palsy children's father was an engineer, made in the 50s, made it for kids, because the life of a cerebral palsy child was largely spent on a sofa or as a shut-in. That was the life. They had iron leggings, and that was the life. So she showed me all these things that Beryl Arbuckle tried to do for children, and she went after page of, like, you know, your grandma might go through old photos with you, and a lot of the photos were Beryl Arbuckle dressing up as Santa Claus, having parties for the kids because they were shut-ins. She threw Sweet 16 parties for the girls, so they should have a life like normal kids have. That to me was, we're going to call it osteopathy, but that was like total caring for a person. That's who Beryl Arbuckle was, that's for sure. I don't know if Josephine Rockow is still alive, but that's who she was, so very touching. Anyway, and I wanted to work it into what we're going to look at. Cranial birth injuries, just treating children, babies in here, couple. Okay, even those of you who are not actually adults once started out as babies. So we see these problems and we see them persist through life. And some of the oddities that I'll show you probably tomorrow, cranial synostosis, some really horrific pictures and whatnot. You'll see some of them in your life, more or less, depending how much you practice and where you practice. But you see everything on a bell curve. So you might not see all the weirdities that I'm going to show you, but you see things that are close to weird, and that's what comes in your office. And when heads are shaped close to weird, they're usually symptomatic. So this is going to be about an hour or so. Morning, Hashem. This is going to be about an hour or so of, it's all written out for you, just some common things that we can look at in the whole birth process. Being born comes with its risks. Starting with hemorrhages, anoxia, and icterus. These are common things. Tissues can tear, there can have small bleeds, areas can get deprived of oxygen, bile can leak out. These are things that we do quickly when a baby's born. We see that the baby breathes, and we say pink up. It's not really a medical word, but say they breathe and the skin color turns nice. And as long as the baby's born, it's breathing, the color's nice, it's not poop in their mouth, which we call meconium. We say, you know, we give them it's called an APGAR score, which I won't go into. Oh, good, he started me. I was a little afraid that he might delay in banging on the pipes, but I'm glad that we're in sync with each other. I want to find out where he lives, and like when he starts dinner or she starts dinner. Huh? Damn it. It's like Santa, right? He's everywhere.
Yep, just like Santa.
You can continue. Okay, so anyway, if that APGAR score is a good APGAR score, 8, 9, or 10, we say everything's fine. But if everything wasn't fine during the process, we find it out later on. When a baby's born, it's important to know that the myelination, which is the covering on your nerves, is not complete. So we see certain problems in life that are just normal problems, bedwetting and things like that, because the myelination on your nerves is not complete. In the Amish world, it's not uncommon for, my son will tell me today, we see people that are 20, 30 years old wet in the bed. And I think that's because they're not marrying first cousins, but the gene pool is not that large. the community's about 200,000. So even though they're not marrying first cousins, still they're seeing a lot of delay. But in a normal situation, myelination doesn't complete around age 8 to 10. So especially the pudendal nerves, which are responsible for micturition, you being able to hold your pee, they don't complete. They're the last to complete. So that's a situation you need to understand.
And interestingly, children, it's rare for children, for some reason we still don't understand, I was just reading a couple articles, that there's no neuropathic pain in children.
Oh, I'm not aware of that.
Yeah, it's like such a rarity, and they can't figure out why. It only happens in adults. Weird.
Good to know, good to know. So this process complete. So you have a tiny little man or a tiny little woman, and it looks like everything is normal, but it's still developing neurologically. And yes?
Aside from bedwetting, what goes along with that?
Well, the most common thing that I can think of is just bedwetting.
That's it.
Well, there's probably more than that, but it's not coming to my brain.
Okay, thanks.
Bedwetting's got a couple of possible etiologies. There's that. In the manipulation world, it's sacrum. If it is sacrum, you should do a treatment or two. They should stop. Psychological is another reason. And a couple little branches on that tree as far as why that psychological might be. And that's what I can think of.
I can see a significant shift in coordination with kids looking at athletics from 8 to 10. The quality of movement is really different than a 10 to 12-year-old. It's going to look more like an adult, right? And start watching sports, team sports, and whatnot. There's a surety around it. I think it's the sciatic nerve is one of the later ones.
I mean, there's a whole process. There's a whole process in your cerebellum, which, off topic for this, but your cerebellum does all the fine motor coordination. And people that do sports or do certain activities, or they're pilots that see things coming at them very fast, they can react faster than we can because of parallel fibers that get made up in the brain. So there are pathways and machineries and processes that will get into place. Yeah, I don't know what else to say about that. So yes.
Thank you.
A note about sutures. Only the main fissures are formed at birth, and there's very few convolutions. So a baby's skull, the sutures are wide, they're not really interdigitated. Your sagittal suture looks like this complicated, we say interdigitated, like fingers coming together, and it's really more like just nubs that are far apart. The sutures will complete as the bones approximate each other, and then specificity will occur as stresses are put on that body. Bones are going to grow according to Wolff's law when stresses are put on them. Birth trauma. Frequently not seen at birth, because as long as the baby can breathe, poop, pee, feed, we say the baby's okay. We don't really see measurable problems until they start falling off the developmental scale. For this reason, many birth traumas appear normal, and the parents may have been told this, which makes things really complicated, especially in the case of autistic kids. Not that it makes any difference anyway. Whatever that history is, if you're in front of me now, it's not going to guide my treatment. But the parents will come and say, she was normal until they got their MMR shot or something like that, and then they will link it because someone else told them that vaccines are bad. And when I'm asked this question a lot as far as pediatrics, should I get my kids vaccinated? And I always give people, I say, well, let me give you my opinion, and let me just give you an addendum. I vaccinated my kids, and I'm not getting reimbursed by the drug companies for it. For me, I felt that the benefits outweighed the risks. Yes, I think there's a downside to it, and yes, there's probably some bad things that happen, but that's a decision I made as a parent, and you make whatever decision you want. But a lot of times the parents will say, well, they were normal. They may not have been normal, because they may have some microhemorrhages or tears or things that just were not apparent at birth. And then I've had people that clearly could show me like a videotape or a CD of what the kid was doing, and then they got vaccinated, and then the kid wasn't doing it. So I'm not giving you an all or nothing. Yeah, I've seen it where this was a kid speaking, and this is a kid who is a flesh robot, can't do anything. But my choice as a parent was I vaccinated my kids and beat them often when it was appropriate, usually in the bathroom. That's where the beatings happen. My kids were misbehaving. I said, you need to go to the bathroom? They said, I don't need to go to the bathroom, but Lewis needs to go to the bathroom. No, Dad, I don't need to go to the bathroom. I said, well, you're going to go to the bathroom. The bathroom was not for going to the
That's so disturbing.
This is my house. Do your house your way, do my house. Actually, I didn't grow up in that much of a corporal punishment household. We didn't get that much. Once I was sitting at the dinner table, and my father, as I was saying earlier, profanity was his true art. So I learned all my words from him. And I said shit at the dinner table with my grandmother. I must have been like 8 or 9. And the hand came so fast from across the table. I didn't even see it, and my teeth were just like chattering. I just got one across the face, and then I made an association that shit makes my face hurt. When I said that word, my face really hurt, and my teeth hurt. And so I didn't say that in front of Grandma, because when I said it in front of my father, I was rewarded. So, this was the learning process in a dysfunctional Sand household. That's my somehow it got me here. Hemispheres of the brain. Baby's brain has just the functions that it needs to survive. That's it. Initial functions at birth: breathing, sucking, digestion, excretion, and God willing, sleep. So if a baby's doing all these things, that's all it needs to do. Respiration, let's look at that. For a baby to breathe well, the dura really needs to be free. I'm not saying that breathing is a cranial sacral problem, but it's a component, okay? Because when you watch a baby breathe, they don't have all the stresses that we have and all the musculature that we have, but the dura needs to be free. Occiput, sacrum, ribcage, diaphragm, linea alba, and the anterior fascia. When you watch a baby breathe, you see the whole belly move. Sucking. Imperative. In order to feed properly, a baby needs to be able to suck and respond properly. In the cranial textbooks, they will tell you that inappropriate feeding of a baby must be hypoglossal nerve dysfunction. I think it's more complicated than that. There's a lot of reasons why a baby might not function, not just something at the base of the neck. But it's one of the things that you'll find in a lot of osteopathic texts, that it's all cranial nerve 12. Yes?
Is that what, I mean, I know, like, a lot of people, I know people treat infants for having, like, trouble sucking. So are they treating, I don't know, like, what are people treating when they're treating for that? Or they're just treating the baby?
What's the question?
When osteopaths or craniosacral therapists treat infants who are having trouble latching or sucking, what are they usually treating?
So your question is, what are they doing?
Yeah, or what's normally going on?
This is the situation, and I can tell you in the Amish world, because the average Amish is having, 8 to 10 kids. Seriously, 8 to 10 is probably an average number. They just say the baby's not feeding right, or not burping right, or they give me some half-garbled story, and that points me in no direction at all. So I'm going to do a craniosacral treatment. I'm going to go all around the vault. I'm looking at the back of the head anyway. I don't see it as a hypoglossal nerve problem. A baby has no way to communicate. If a baby's not feeding well, or if it's not digesting well, you have to understand that the system is brand new. It's like you have this factory, but it's brand new. It's just been switched on. So when you eat too much chili or something like that, and you're uncomfortable, and you're going back and forth to the bathroom, you know you're doing this because you have erred in your judgment, as I often do, and you can deal with it. Okay, a baby can't. So the baby does what? It's either getting diarrhea, constipation, and crying, because every little pain is going to make it cry. That's the only way it has to communicate. So if a baby's not feeding properly, I got to give you this because this is the osteopathic scientific version of what's going on. But maybe it's not sucking because it's feeling irritable, or as the milk's coming in, something's making it digest funny. And osteopathically, you do some treatment or some body work of whatever title, some gentle treatment, babies respond to it. They start feeding better generally. Let's look at digestion specifically. These are extreme conditions, so you're not going to, pyloric stenosis, that's a surgeon's job. But what you're seeing is on that bell curve is maybe some pyloric tightness, not stenosis. Stenosis means it's closed off. We were told, and many of you were probably told when you're new parents, told by the pediatrician to watch for projectile vomiting, okay, because that's going to be the sign for pyloric stenosis. If the pylorus, this last sphincter here in the stomach, if it closes off, if food absolutely won't go down, it absolutely is going to violently go in the other direction. That's Were you told that by your pediatrician?
No.
No? Okay. So we were. And I'm sure that we bugged him a few times about everything in the world. If it won't go down, they don't just throw up, it's projectile. And so obviously a lot of people, and even in the Amish world, he's having projectile vomiting. And I look at the baby, the baby's going, bleh. That's not projectile vomiting, that's called vomiting. It's called vomiting. If you're in like the ghetto areas, it's vomiting. Vomiting. That is neither projectile vomiting. Projectile vomiting is literally like,
Linda Blair.
I can get you from here, okay? And I've seen it,
With
okay?
babies.
And that's surgical. You're going to go to the surgeon. The baby squirts it out like in the funny movies that you see. Then that's really stenotic. And my recommendation is you go see a surgeon now. But what I've seen is somewhere between here and there, you know, where it's got some good distance, some good air. When this actually closes off, you can see it as an X-ray finding, and it looks like an almond. But when the muscle becomes so tight, the density changes. So you're going to see things maybe where they're just vomiting and there's some tension there, and they'll respond to visceral treatment, they'll respond to cranial treatment, respond to different titles of different things. But to address this area, we have tools for that. So on the bell curve, we're seeing them certainly before that. This, I've seen a couple of cases of this where I know it's documented by MDs that this was the problem. Volvulus is a twist. I don't want, and again, if I happen to know that this really is, I'm treating the symptoms, which is throwing up and irritability. I don't know how to untwist somebody's guts or tell them that I untwisted it. If I suspected this again, I would, if the problem doesn't resolve, go see the MD, go see the surgeon. But this happens also. And that is if the gut twists around, what is the real danger in that? What's the risk in that?
They get pinched off and I get blood flow.
Yeah, and then what happens? You have ischemia. You have ischemia followed by hypoxia followed by necrosis. So you can't live with that. When that cascade happens and you have necrosis, bowel dies, followed by you dying. So, and I've been told there's certain dogs that you can't run aggressively all the time, or you shouldn't, because they're subject to this. Do you know that?
Yeah, that's right.
I've been told by like Great Danes, they have a very loose gut, so.
Irish Wolfhound, same thing. Yeah.
Okay, so anyway, so I've seen this. Again, I don't want to tell you that, you know, I'm the intervention for it, but I've seen vomiting, irritability, been able to treat it, resolve it. I've seen vomiting, irritability get worse, not be able to resolve it, go to the MD, and then this is what they had. Much more rare. One case comes to mind, I think maybe a second, that I know actually had an intussusception. So it's much more rare. Intussusception is, if you can think of taking like a big garden hose straw and then invaginating it upon itself. So the straw collapses on the inside, which is what they're showing. And it will, if you collapse this into the cecum, it'll close off the lumen. And again, the result is going to be the same thing. Ischemia, hypoxia, and then necrosis. And when I say the surgeon's going to fix this, what they're going to do is they're going to cut it out. They're going to remove that part. Let's talk about excretion. I love to talk about excretion, especially as I get older. It seems to be much more on my mind. And I'll just stop there because somewhere it's going to end up on Facebook. What are the problems that we see with excretion? Constipation, diarrhea, and pain. In the adult world, what is that? What is that combination if you're healthy otherwise? It's IBS. According to the AMA statistics, it's either 1 in 4 or 1 in 5, I forget. In an American population, 1 in 4, 1 in 5 people has IBS. Which means you have diarrhea, constipation, one or the other, plus pain, and you have a negative colonoscopy. So they stick a scope up there, you don't have Crohn's disease, you don't have ulcerative colitis, you don't have cancer, but yet you have this problem.
You have stress.
You have
Stress.
I've read about it. I read about it once in a book. I haven't experienced it yet. I think I have had some symptoms. But you and I will talk later.
Switching in the eye.
Yeah, I saw a photo. It looked just as you look right now, actually. It's amazing. You know, it's easy for us to stand up here and poo-poo the MD and say whatever. They're great. They're great at acute medicine. If you're having a heart attack, please don't make an appointment at my office. You know, if you're calling with chest pressure, please stop the ER first. So they're good at the acute problems. They're not equipped for investigating. And for investigating things like this, the best that they're often going to do is just label it for you and say, hey, you're not going to die. And you're not going to die from that. You're just going to have crappy quality of life. And these are treatable, certainly treatable by any number of body works. And for baby, quite common. Again, because it's new machinery that's been turned on. Sleep. Oh, yes. Ask me any questions you want. That's what I'm here for.
So I guess not so much baby newborn, but in young, like 1, 2-year-olds, withholding poop. Is there anything you can say about that? Or
What do you mean with, I don't understand what you mean by withholding.
I guess there's something that where pediatricians would say it's not that the child is actually constipated, like it's not that fiber and water is in the situation the child is actually pouring it in. Maybe because they're scared that it for painful ones or just other psychological.
Well, I'm going to go with the two things that you just said. Either there's some psychological reason about the baby messing their pants and the parents, giving them a problem over it, or something psychological, or that they're trying to avoid some pain. So it falls into the category of something is painful for them, and maybe the bowels. I would have to guess and say it's a little bit slow. Diarrhea, you wouldn't be able to hold it in too much. I believe we all have that common experience. Okay? When the bell's ringing, you got to go. Okay, but if you're holding it in otherwise because it's painful, I'd have to go with constipation or something psychological. Sometimes you get these problems, and then you meet the parents and you go, it's all so clear to me now.
Yeah.
You see a parent like myself, why is that guy taking the kid to the bathroom? You don't have to go to the bathroom. Okay. Sleep. I know I shared with somebody in this room yesterday. My patients would say to me, my regular practice, they go, you're so calm. I would get that like as a compliment all the time. I don't know why. And I would love it. And if I knew the patient, I'd say, really? Come back to my house for dinner. I'm going to be done work in a few hours and see if you still retain that opinion. Because I'd walk in, it's just like a jungle that was just completely let loose all day, waiting for me to come home and attack me. But that's just me. So let's talk about sleep. Newborns who sleep poorly or irritable are often called colic. This was in my day. You have a baby who's irritable. You know what, Joe? You have a colicky baby. Oh, thank you for that medical words of wisdom. And I go back with a crying baby. What do you do with that? It's just a nebulous term. Doesn't really mean anything. It's diagnosed without any etiology. Many theorize that colicky baby is due to inappropriate feeding, digestion, blah, 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 blah. A baby has one way to communicate with you. And this is the easiest, I love that as a diagnosis for somebody to come in and go, the baby's kind of irritable. Because I got a real chance of hitting one out of the park, making that problem go away. If the doctor knows why they have a problem, that's always much worse. If they've identified some medical condition, that's much worse. If they've identified a big nothing, that's where we absolutely have a good chance at the big nothing. Meaning there's not a tumor, there's not some neurological condition, the baby's you're just unlucky. No, the baby's got some tension or some pain somewhere with only one way to communicate. So that term colic is, I was still hearing that even in my recent practice. Do you treat babies with colic? Yes, I love babies with colic. No problem. Okay, let's look at the birth process, mechanisms of injury. This is all a reduction. It's a reduction from Beryl Arbuckle's work in 1944 that she published, and then some other stuff I put in from Jane Carrero, some people in New England who did a lot of work with babies. She looked at possible strain patterns. She felt that strains that happened during the normal birth process, that somehow these were an impediment to intracranial circulation and thereby caused some sort of strain on the circulatory system. No one else was thinking this, that a strain in the circulatory system during the birth process somehow was responsible for why your baby was symptomatic. Do you guys not have this, or?
It's in your,
Did Paul send it?
Yeah.
You have this, right? Everybody has
I'm writing by.
it. Okay, all right. Okay. If I'm going too fast, you need me to slow down. If you need to go to the bathroom, you let me know if you need to go to the bathroom. Yes.
No, I
Yes.
mean like there's a strain in the cranium because of the birth process, and then I'm not sure what exactly.
We're going to look at it more specifically. The process of being born,
Yeah.
the process of getting here from the netherworld, involves squashing your head, elongating it, pulling on dura, and she felt that some think, for most of us, this process we survived well. And for some people, she was trying to explain cerebral palsy. And cerebral palsy, that was a big part of her practice, the CP children. Cerebral palsy is largely a garbage can diagnosis, and what I mean by that is we don't know why they have it. It's very rare that we can identify a particular damage in the area of the brain and say this happened to you, and this happened to you because you had a traumatic birth. So kids that had spasticity, she was trying to think, why do they have it? What could have happened to this child during the birth process that now they're spastic? Maybe they had a strain that happened to them. That's what she was trying to say. Circulatory system, a strain on the circulatory system, if we, by strain meaning some sort of temporary ischemia, would result in some sort of lack of oxygen, which would be anoxemia, which would result in some nerve tissue damage, and possibly some cerebral bleeding. And again, we might not find this out at birth, we might find it out a little bit later. I had a gentleman that I treated who was an adult, I don't know how old he was at the time, probably late 30s, 40, something like that. Had a car accident, and he said he had brain injury from the car accident, but no one could document. And I was treating him. He had, from my perspective, somatic dysfunction and cranial dysfunctions that I was treating. And one of the things that was difficult to prove was, he said he could do calculus in his head before the accident and was not able to do it afterwards. He was the manager of a PetSmart before, he's still the manager of a PetSmart. But he's telling me in a very honest way, I don't think like I used to think, and how do you prove that? And after a lot of struggle, I was able to get a PET scan for him, because PET scans are very expensive. And we were able to document some micro infarcts that happened in his brain that wouldn't show up on a regular CAT scan with or without contrast, wouldn't show up on an MRI with or without contrast. So the brain is so complicated, these little things can happen, and you can have these deficits that it's sometimes impossible to prove. So this is what she was trying to say. Maybe something happened and there's something damaged. Of course, at least in CP, it's very obvious. And a guy who suddenly can't think as wonderfully as he did before, it's almost impossible to try and prove. Let's look at delivery and uterine contractions. During the contraction, there's a muscular contraction which causes blood in the CSF to be squeezed out of the skull. Viola Fryman and Melissa T. Tamble, another DO, they would say that normal vaginal delivery, that is the first cranial treatment. Okay, but maybe something happened to you during this process and you didn't survive it so well. There's a period of contraction followed by relaxation, which causes a dilation followed by edema. This is a normal process. Then there's a period of elongation. She felt that maybe elongation of the frontal occipital diameter, extension really, is something that could result on a strain on the falx cerebri, strain on the tentorium, strain on the veins of Galen, which are the veins that drop in through the actual gray matter. Whether or not this is what happened or caused it, I don't know. Excuse me. But a woman was thinking this in the late 30s and early 40s and presented it. Little bit of tidbit, wouldn't be informational for anybody, but I happened to get it from an old friend of mine who's now at the end of his life, Galen Young. Galen Young was working at Philadelphia Osteopathic when she was fired from Philadelphia Osteopathic over a political battle. And Philadelphia was at one time a bastion for cranial osteopathy, and largely part due to this woman, and she was fired over the loudspeaker. Like, she had a dogfight with Angus Cathy, who was an anatomist, physiologist, osteopath, who didn't like cranial. And apparently, Galen told me that there was just like an announcement over the speaker system that she's fired. You know, get your things and get out. Our world's very political, the osteopathic world. Because I know your worlds are not political at all. Galen Young is a very good friend of mine. His father was the first board-certified osteopathic surgeon in the 30s, and was doing manipulation up until 94, and then died at 96. And I have his original cadaver skeleton he gave to me. And Galen Young Jr., who's now 1,000 years old, my friend, he's at the end of his life. And he was friends with Angus Cathy and gave me I have a whole stack of Angus Cathy's original writings that he said, here, make this into a book. I'm like, do I look like the guy who's going to do that? He's like, I'm giving this to you. Anyway, so this is whole weird history you get from these old people. You know, if you know old people in your life, get the information now. I still ask my parents stories when I'm with them. Tell me again how this was, how that was. That oral tradition gets lost. Okay, features of the infant cranium. That was all non-osteopathic. The infant cranium, 6 fontanelles you actually have. Bregma and lambda is what we know, the front and back. But you actually have asterion and pterion. Pterion is right here where your sphenoidal bone and your frontal bone and your parietal bone are going to come together. And asterion is all the way back here, your squamosal suture and your occipital and your the other one, your parietal bone. That closes up almost immediately, asterion, and then pterion is gone. The last one that's left is bregma. That's the big one. You know, don't touch the baby's soft spot in the head. Your uncle and I, you're arranging a dinner date for us. Okay. Steve's uncle. Bregma here. Okay, this is the soft spot. Here's, I don't know the age of this skull, okay, but here you can see pterion, asterion, lambda, infant skull. These are from Jane Carrero wrote a book. You can ask me the title later and I'll get it for you, but it's Osteopathy in Children, something like that. She's an osteopath with the New England School, and she's done a lot of wonderful work and dissections. Here's newborn suture. Again, sutures are wide. Here's bregma. Notice how far back it is. You know, that what is the coronal suture here, it's not here in your head, okay? It's about 40% back on your head. As you lay back on the table and your skull buries into the table, it's about halfway in the middle of your head. Molding. The head has to elongate, and the bones are very bendable. Elongation of the head, reduction of the cranial cavity, the size of the brain as it's getting squashed. This is what has to happen for a normal vaginal delivery. We say in the C-section world, you know, oh, baby's got such a nice round head, but maybe you were supposed to go through that process. In the case of a narrow pelvis, the parietals might override the sagittal suture. I've seen a handful of times, it's come into the office, where you can just clearly see the sutures are overriding. And that's really nice when it comes in, because it's really easy to fix right in one treatment. They come in looking like a messed up cone head. You just play a little bit and they leave like that. That doesn't mean that they didn't have any damage or some problem didn't happen or they didn't strain something in their vertex. But as far as morphologically making it look nice, it's pretty easy to do. So she was trying to explain how that can happen. And she also felt that that would leave some tears near the vertex, top of your cranium.
Do you find forceps babies have more issues in that way?
I don't, in the Amish world, it's all midwives. Most of my, you know,
Right.
and a lot of times I don't actually know what the history's going to be. In my generation when I was born, I think my sister was a forceps baby, and I think I was just like a magical baby when I came. They said, here he is. We've waited for him. Little Stephen. So I don't know. I can't give you any kind of comparison. It can't be as good getting forceps going in and grabbing you as it can natural delivery. But I'm not ready to poo-poo the doctors if they're doing it because there's the baby's at risk, the mother's at risk. In my sister's day, and then I guess in my day was the end of it, they didn't have any thought about it. Just go in and let's just make this quicker. Now they certainly do. They certainly do. Because any baby who's born without all of their fingers and toes for whatever reason, everybody's looking to make that doctor, his family, his mother, his first cousin on his Aunt Jenny's side pay for it. So today they're really giving a thought about it. Is this normal?
Suction.
It's a bit extreme, but this is normal.
Yeah.
This is a normal cone head. This is Beldar. So, you know, certainly she felt that, this is from Jane Carrero's work, that using forceps could cause some abnormalities, and that's absolutely true. One of my teachers, and we became friends, obstetrician, you know, he thinks twice before he does anything like that. I asked him, I said, after I just saw him within the last 2 years, before I went to Thailand, I said, does anything scare you, John? He said, shoulder dystocia. Dystocia is presentation. He said, if he looks in the vagina and he sees the shoulder sticking out, he said, I've been doing this 35 years. That's where they got to break the baby's clavicle and turn the baby. He said, I'm as scared as the first time I did it, because you just never know what's going to happen.
I have a client that was pulled out by her arm. I guess she was shoulder, but the arm was exposed. And now the whole arm her whole life has been retracted because...
She's got Erb's palsy.
No, not a palsy.
Okay.
A full contraction
Okay.
because the brachial plexus is damaged. And one time I had her, so we were working all this nerve work, all teasing this out, and she got probably about a good 30% more range and relaxation around. One day, I had her face down with her right arm hanging off so I could work a little bit on the back side or tears and so forth. Complete communication, kept asking her if everything was comfortable. I wanted to make sure. She turned her head the other way, not 15 minutes. And we're talking the whole time and I keep keeping up with her. She gets off the table, palsy. And she was like that for a few months. Luckily, she had just lost her job the week before, so it kind of worked out, but she was pretty upset. But I mean, at the same time, it was like, we were talking, I kept asking, and she didn't feel any pain. It was like, normally you're supposed to feel pain, a little tingly. She didn't feel any pain.
It's an imperfect world. The only way you're never going to have something like that is to quit your job right now and become like a clerk or something. Somebody asked me somewhere recently, I don't know, every week I'm somewhere different, I forget where it was. I'm afraid of doing something because I'll make a mistake. I'm like, well, quit now. I got your answer for you, quit now. I'd like to think that everyone that didn't come back to me said got a wonderful result. No, some didn't come back, they didn't like what I did, they were too uncomfortable. Someone who was a close friend of mine called me the day after her hospital admission from throwing an embolus that she said, I think you did this to me. And I said, yeah, I think I did too. You're going to make mistakes. Friends came to me after a car accident, and I did some aggressive myofascial work on her. Had been cleared from the hospital. Didn't have a clot embolus, but you can get a fat embolus as a result of a car accident. So, yeah, I probably moved it. She said, I think you did this to me. And I said, yeah, I think I did too. I'm really sorry. What are you going to do? Did I get sued? No. A lot of that has to do with your demeanor. I made a mistake. Would I have done something differently if I saw that same person in the same situation right now? I'd do the exact same things I would have done. A fat embolus is a really rare thing. How can you know? So you're unwinding her. She had this thing happen at birth, and she reactivates something in her brain. How could you know? What could you do differently? Nothing, probably.
I would have done the same thing.
Same thing. Anyway, okay, forceps. Let's look at breech presentation. As somebody asked me once, said, well, because this happens in 4 or 5% of the population, it's just a normal variant. Well, it is a normal variant, but different things happen when you're a breech presentation, so you are at more risk. Because it causes a rapid molding, which definitely is going to put more strains on your head.
Rapid molding means rapid molding.
Changing, like Play-Doh. The head has to rapidly, the bones are moving around in a sheet, between bed sheets of, your vault is bones that are formed in membrane as opposed to cartilage. So it can just kind of move around like Play-Doh. And if you have to do that rapidly and the vessels don't get to accommodate, you're at more risk for tearing, vessel tears.
Because they're pulling on your feet, that's why it's rapid, yeah.
Well, then the head's also not in the same presentation as it would be.
It's not compression, it's a distraction.
Yep. So you have a rotation of the screma and the occiput. She felt that in a breech presentation, this might cause some compensatory flattening of the opposite parietal bone. She's just trying to theorize why someone with a breech presentation now has cerebral palsy. What could have happened to them? That's what she was trying to do. That if the squama and the basilar and condylar parts of the whole occiput all rotated together, because it's all in pieces in a baby, that there might not be tearing, but there could be some increased tension in the falx cerebri, and therefore rotate the petrous portions of the temporal bone. I'm not saying this is all true. I'm saying this is what she was trying to theorize as to why she saw the end result. Question?
Well, I have a colleague who has cerebral palsy, and when I worked on her, it was like her parietals are like almost completely flat. It's like her occiput too. It's like a sharp corner.
When I get that with parents, I'll have the parents just They want to know what I'm doing. They want to try and understand what I'm doing. When I get the kid that has the corners on the head and the parietal horns, I'll bring the parent over here and I'll have them put their hands on the head the way I'm doing it sitting at the table. And then they'll feel that corner and I go, you won't feel that on other kids. And a lot of times, often, I can change that corner. I don't know if it's going to change the condition always, but I want them to see that, especially in a kid who's a young kid, because that corner, you can change it. Torsions. She was trying to consider how at the base of the sphenoid, base of the occiput, a torsion can be put on. She felt that a torsional strain would somehow put a strain on the medulla, which would in turn put a torsion on the cerebral aqueduct, which is where the CSF is going, and that this would ultimately affect the pyramidal tracts. The pyramidal tracts are your posterior white columns. None of this do you have to know, but it's just it's your posterior white columns in your spinal cord that go up to your cerebellum, and that this was affecting their coordination. So she looked at all this different thing. I wrote it all out, but it's really kind of complicated. So if you squeeze the cerebral aqueduct, that's going to affect some juice that's going to the pyramidal tracts, or result in crowding of the aqueduct, which would cause some stricture in the middle cerebral artery. Your middle cerebral artery is what your upper motor neurons, that's where they get their juice. I treated one child once who had, now I'm getting it backwards talking to you, either had only upper motor neurons or he had only lower motor neurons. I think he had only lower motor neurons. And he just crawled on the floor like a worm. That's how he could get around. This. And it took like a lot of sessions before I could understand what he was saying. Fully cognizant. Actually really quite smart. But just, it was terrible. He could only crawl like a worm. I treated him as a charity case for a lot of years until I couldn't deal with his mother. His mother was crazy. She, asked me at lunch. I couldn't deal with the mother. As I said, when you want to see the dysfunction, look at the parents. I'm sure my son's showing my photo around somewhere. Like, this is why. I know who I am. There he is. He's in New York right now. Go get him. Virchow said that the growth of bone does not take place. The growth of bone does not take place perpendicular to sutural stenosis, but parallel to this, we have further deformity of growth. I'm going to show you some photos. We're going to go into all what cranial synostosis does. But when the sutures are closed, they don't grow the way that you think they're going to grow. You think that if this is closed here, you're going to grow like this, and you don't. You seem to grow more into the suture and become very deformed. So this paragraph, I got 2 whole lectures on it. The observation is that strains become a vicious cycle. The more you have a strain, the more the growth goes funny and it causes further strain. And we're gonna look at funny-looking kids in a moment. So correction is essential. It's important to remember that basilar ossification is not complete. The occiput is not complete until about 6 to 8 years. So any corrections you can make there, as soon as the kid comes out and they wipe it off, the sooner you treat it, the better.
Basilar?
Pardon me?
The sena basilar is not ossified until 6 to 8?
Until about 6 or 8.
Uh-huh.
The vault bones are formed in membrane, and they have a little bit more flexibility because they're formed in membrane as opposed to cartilage. Primarily important to relieve tension on the falx and the tentorium is what she felt. I think you should just do it, period. There's a study, I've not been able to ferret it out, but she's really a real brainiac, Millicent T. Tamble. And she went to the Kirksville School. And she did work with Violet Fryman, where I think they did a study on treating newborns, and I think it was where the number in the study was a large number of every newborn giving them a cranial treatment, and with I think 0 incidents of colicky reports. You can only do that in some place like Kirksville, Missouri. Have access to 1,000 babies and do that. There should be a study, I've not been able to find it, but I remember her speaking about it. So anyway, treating babies, you shouldn't be afraid of it. If you're not sure with babies, just don't do things that are compressive, just do everything decompressive. Modern medicine and the FLK. This I still saw this in charts when I was in medical school. FLK, do you know what FLK is? Funny looking kid. Yeah. There's an FLK right there. So I still saw charts where it said, we would put a chart, I saw a 28-year-old AA, and then you put the little symbol for man or woman, and it meant African American. Now in the politically correct world, you can't say that because AA could be Asian American, African American, I guess Argentinian American. I don't know what it would be, but they've extrapolated it so much. But FLK, I still saw it in charts. Couldn't write it today because something happened with that kid. They're going to go through all your medical records and go, well, Dr. Mona, apparently you thought Freddie was funny looking, you know, and you're going to have to describe what it meant. What it meant was, kid's got an odd-shaped coconut. And so I just wrote down FLK. Didn't mean there's something wrong with him. I meant that that's really odd looking. That's notable. That's what it meant. Coconut, skull, same thing.
So OSC would be easier to explain.
OSC.
Odd shaped.
I like that. You know, you're proactive. That's the thing about you. Odd-shaped. Between you and I, it's odd-shaped coconut. To them, odd-shaped cranium. Clearly, Your Honor, that's what I meant. So, let's talk about ADD and ADHD for a moment. One of my patients was a nurse for a particular middle school in Philadelphia. Middle school in Philadelphia is grades 6, 7, and 8. And when I went to school, I wasn't on medication, but if somebody had medication, their mom gave it to them, hey, take a pill at lunch. In today's world, it's not that. You have to give the medication to the school, and the school has to dispense it to the kids through the nurse's office. So I had this nurse as a patient, and she said to me, do you know how many children come to get medication at lunch in her school? And it was a mind-numbing number. And this is a patient from 10 or 15 years ago. She told me 60% of her kids in her school she was dispensing a medication to. 60. Antidepressants, anxiolytics, and Ritalin, stuff like that. Philadelphia. You know what? If there's something wrong with your kid, I don't doubt that some kids need medication. It can't be 60% of the kids that need it. Yes?
It's not only Philadelphia. I was a special ed director for a number of years in New York's different school districts. And we had classroom teachers meeting with parents and recommending that they see a neurologist because the child needed medication and it was really getting out of hand. But it was one of those garbage can diagnoses that everything fell, it must be ADD.
You know, I had a speech problem when I was young. I said shit in front of my grandmother. I got a medical treatment. And I was cured. So, some kids need it. You know, I've seen a kid who's anhedonic, a kid who lost interest in any video games, and that really scared me. I saw a kid like that. That kid I'm concerned about, but it can't be 60% of the kids. But I don't know, we live in such a society where, society it's a bell curve. Somebody's going to be an A student, most people are going to be C students, and somebody's going to be failing and is really going to need our help. So parents think, well, my kid's not an AB student, so there's got to be medication to fix it. That's the problem. And you have drug companies that have a bigger budget than some small third world countries, telling them that I'm going to make your kid smarter or whatever. So it's a big problem. And I attended a speech by, the name escapes me now, he runs Seashore House in Philadelphia. And he started out his speech saying that he was diagnosed with one of these two. He said, the longer the name, he said, the less we know about in medicine. Bang, he started out the speech with just honesty.
Nice.
So when I see a kid who's ADD, ADHD, these are people that are treatable. When I've been able to help them, they've been ones that had tight craniums, and I did something for a tight cranium, and I saw a result.
Call you all together because I think you might be making a mistake putting your children on Ritalin.
But our kids have attention deficit disorder, Chef. They can't pay attention in school without it.
I know you want to help your kids, but I brought over a videotape to show you that there are alternatives to Ritalin. There's this doctor in Northern California who is doing really amazing things with kids who have ADD. I want you to watch this tape.
Hello, I'm Dr. Richard Shea, here to tell you about my exciting new drug-free treatment for children with attention deficit disorder. This treatment is fast and effective and doesn't use harmful drugs. Watch closely as I apply treatment to the first child. Sit down and study! Sit down and study! Stop crying and do your schoolwork! For more information on my bold new treatments, please send away for this free brochure entitled
Shea come to South Park for a small fee.
I get the same reaction everywhere showing that. This is what I think about ADD and ADHD. Some kids, you know, their parents are wanting something from me, or they're wanting something from medication. This is just how the child is. But the most extreme example that I'll tell you very quickly is, I had a child who came to me, I think he was around 14-ish, where I treated the father once or twice, treated the mother. Mother loved osteopathy for everything. She said, my son so-and-so is having these problems in school, and he's got ADD, is there something you can do for him? Sure, let's try. She brought him to me, okay, and the kid is around 14. He came to me, and he was not a nice child. Okay, he came to me, he says, I'm only here, it's a bunch of bullshit, you're not even a real doctor. I mean, he dressed me up, and he dressed me up right, he hit all the buttons right away. Okay, you're not even a real doctor, you know, you're not even doing medicine or anything like that. He's only here because mom's making me come here, you know, I think it's a bunch of shit what you do, blah, blah, blah. I'm like, just lay down. Yeah, young man, just lay down at the table, please. You need to go to the bathroom? You want to go to the bathroom before you lay down. I treated that kid, and I'm like, this kid's just demon spawn. That's what your problem is. And he had, you know, had whatever cranial things that felt tight on me, whatever. I did my treatment, and it was light switch. He went from a disrespectful, not nice child, okay, to, I don't know, I treated him once or twice. It was like a light switch to an AB student. I know that kid to this day because he's like 28 or 29 years old. Now, the other part of this story is, I did a couple of things. There was magical treatment, his behavior changed, his schoolwork changed, everything changed. About a year or a year and a half later, the mother found very large size women's underwear in the father's drawer, and brassieres and whatever, and the father was a cross-dresser. So this resulted in a terrible divorce, instability in the family, and you can imagine, if the kid was going to regress, if it was just a behavioral thing, he's got every excuse now to do it, finding out that his father's a cross-dresser. And nothing ever changed with this kid. And I don't care about the cross-dressing, that's not the issue for me. I'm talking about divorce. I'm talking about whatever he believed about his father, pulling the rug out from under him. Whatever that did to him psychologically, his behavior never changed. Became just the most lovely young boy. So when you see it, when you see someone who's got a behavioral issue, and I've seen a number of them, and they have something tight in their head. I can't apply osteopathy and say, you have your problems, you're getting B, let's do osteopathy for an A for you in school. All I can do is say, your head feels tight, let me do something to that tight head, and then see if something changes. And if it does, it's rapid, and it's dramatic. It's quick. And there's this treatment as well. I was a student in that school. Okay, these are some, this is from Jane Carrero's work, and I put in some neurosurgical stuff from here. And any questions, just stop me. This is a line that the surgeons will look at here, this median axial stem. Just to note the difference between a child's skull and an adult skull. The child's skull, it's all vault. Until the face is starting to grow and the skull is getting longer, it's all vault. Just another post-mortem view. This is all vault. Everything is kind of indistinct because stresses have not been placed on this skull yet. So the features are going to become more as this child starts to eat. There's another guy named Paul Dart who's out in Oregon, I believe. He's an MD who's done a lot of work with the Cranial Academy, and he talks about changing people's prescriptions. And he's a very science-oriented guy. I'm not really, but he talks about changing them with cranial dysfunction as far as helping their prescriptions. What I can say is I have been able to help some people with ocular problems, but I don't know about, reducing your prescription on your glasses. There's a lot of theories. This is the eyeball and extension, this is the eyeball and flexion, and this might change your farsightedness or your nearsightedness. And I conceptually, I look at that, and then I step away from the TV and I say, well, but you're going through flexion and extension constantly, so if that's true, this point's changing. So I don't really know. But he says he's been able to do a lot of work with adjusting prescription. He's a board-certified ophthalmologist. Very interesting guy, but can put you to sleep in about like 30 seconds, like a sleeping pill. Good guy, though.
What's his name?
Paul Dart, D-A-R-T. And last, I was trying to find some, my friends in Korea are interested in if he's done any writings, and I had
probably 5 or 6 years ago, asked him, he said he was working on a book. So if he does have a book, it would be very interesting. And he's very good guy. Anyway, consider the effects of sphenoidal strain. Maybe it's evident with bulging eyes. Of course, there's other reasons why your eyes can bulge. Your eyes can bulge with hyperthyroidism, which I had when I was younger. My father had, but I never got that bulging eyes. I actually got, if you saw me when I was younger, my eyes look bulged now, but it's because my lids retracted, not because my eyes bugged out. My dad had bug eyes. My eyeballs are out here. Can impair your vision. She felt that maybe this caused some effect on the optic chiasm and caused tension in the ocular nerve. Again, she's trying to think of the pathophysiology of why she was seeing these problems. This is from Jane Carrero, trying to theorize about torsional strains from vacuum extraction. It's another way to pull the baby out, that maybe that was causing some traction on the vertex. I'm not saying any of these are true. I'm just saying that they're not normal situations, but you're doing it because the mother's in trouble, the baby's in trouble. Visual problems. Let's talk about that for a moment. Strabismus, amblyopia, hyperopia, myopia, farsightedness, nearsightedness, lazy eye, crossed eyes. Crossed eyes, I can't say I've ever changed anybody's crossed eyes. Amblyopia, changed a lot of lazy eyes. Many. When the eyes start to wander like this, you have double vision, so you have depth perception. When the eye starts to wander a little bit, you're going to get fuzzy and you're going to start to get headaches. If it wanders enough, often enough, the occipital lobe will shut that down because you can't live with diplopia, which is double vision. I have had that same guy who had the said he could do calculus and couldn't do calculus. He was a patient of mine for a few years. He was the only one who gave me this weirdity that we could document. And as he had amblyopia as a kid, and I guess he had it corrected in some way because I didn't notice it on him. And I treated him for his other aches and complaints, and I can't think as well, and he said he could think better, and I had to document his case for the lawyers. And he said, you know, I can see in this eye again. And I said, can you go backwards on that conversation? What do you mean you can see in this eye again? He said, well, I haven't been able to see in this eye since I was a kid. And I said, you're seeing in that eye. And he started being able to see shading and whatnot. So what I've learned from my uncle, who's 71-year-old retired physician, PhD chemist from Harvard, who studies more than I can imagine still. The brain has a lot of plasticity to it that they've been able to document. The brain can, your occipital lobe, if we start to see like this, it'll shut it down so that you just see one vision. And our thinking is that will not come back. But the brain has the ability to have other gyri of the brain take care of those functions. That's been proven. So, interesting. He was the only case like that, but I've had a lot of where I've gotten the eyes back together. There's a lot of things that might cause that too, so it's not one cause of an eye wandering. I think a cranial strain could be somehow affecting the nerves, affecting the muscles. It has to be if I've been able to make a difference. But if there's other structural reasons, maybe not. Vestibular cochlear dysfunctions, chronic otitis media. This is a real winner for body work. People come to the door, they're having chronic, I forget what the exact definition is, but chronicity should be, I think, 6 months, at least 6 months duration. The kid has had multiple earaches. You do a temporal release on them, and I'll show the parents how to do it. Statistically, my own statistics, 2/3 of those kids are going to help. 1/3, their anatomy's too weird, I don't seem to help them, but 2/3, I'm going to get those kids better, and I have another few slides on that. Headaches. Kids shouldn't have headaches. You should have a headache. You work, you owe people money, you should have a headache. Okay, but kids, when a kid comes in, a teenager, they're having headaches, or a 9-year-old with headaches, I either find the answer for that, or I want to get them somewhere where someone's going to look at them neurologically and find the reason, because they should not have headaches. Vertigo, kids, no way. This is an adult complaint. I've only seen a handful of kids, and I've either been able to help them, or I get them, I found a few brain tumors and things like that. Yes?
But kids with scoliosis and deviation in the ribs, and they can have headaches.
Yeah, sure. That's a reason to have headaches.
Yeah.
Vertigo and dizziness, it's not the same thing. So I always have to differentiate when someone says, I have vertigo, they've heard that term. Vertigo is I'm standing here now and I feel like that room is moving. 2 nights ago, I experienced that, but it was alcohol related. Okay, but usually when people are saying that they have vertigo, I'm like, you have dizziness? Yeah, I'm dizzy. Do you feel like the room's moving? No. So vertigo, I don't see it too much. And in the adult world, if they've been to the MD, there's one drug we use for it called Antivert that may help for Meniere's disease. And so usually, if I see them, it hasn't worked.
What about the crystals?
Well, the Otilis, which are the crystals, and I have a few slides coming up on them, so we'll talk about
Can you
particular.
differentiate between crystal caused?
Can I? No.
No.
I might treat you, you might get better, but what the exact cause was, I don't know. And I don't investigate too much. It's not that I'm lazy, it's just not what my job is. When they come to me, they've usually been the gamut of whatever else, and they give me all the testing showing that things are normal. When they show me, I have this, I had one fella, and they show me, here's the damage I had done to my ear in 2 failed ear surgeries. He was coach, what do you call it, umpiring a softball game. And somebody went like this, and he happened to be standing right there, and he got a contra coup head injury. Contra coup is you hit here and it blows out bones here. Because it depends on the vectors of force. If the vectors of force can pass through your body, you have no injury. That's how karate works. You go like this, you hit the board, force goes here down your back into the ground. Or you hit the board wrong and the force goes here and you cry like a baby in front of your friends and break your hand. So he had a contra coup injury here and it blew out the ossicles here. And his complaint was walking, he said it was like metal. I changed the sound, couldn't make it go away. When the doctors come and they go, I have vertigo, I have headaches, I have this, I have that. Here, I've been to the NT and a real heavy stack and it says they're normal, that's where we have the best chance of helping them. Because they have no way of documenting fascial tightness, tenderness. I don't care about their belief in whether or not body works, blah, blah, blah. None of it matters. What matters is I know the NT's not lazy. And I know they did $1 zillion worth of testing. And I'm glad. There's no tumor in your head. Thank God. There's no AV malformation. There's no... So we have a good chance of helping this. I know this is a long lecture, but I'm going to get through and then I'll give everybody a break. I want to give you the underground, the underpinning of what kids go through because you were once a little tiny lady. Okay? Let's look at the ear specifically. Here's your ear canal, tympanic membrane, and the eustachian tube. For kids that are getting chronic earaches, this is the problem. Okay? And the problem is, it's the orientation of this eustachian tube. So in 2/3 of these people, we're going to be able to help them. And in about 1/3 of them, I'm going to do a couple of treatments, 3 or 4 treatments, and I'm going to be able to change some of the tension around this tube. Here's another representation. Okay, there it's showing the eustachian tube here, and here it goes more posterior laterally and drains more naturally. I do something to change the fascial tension by playing with the ear with the simple techniques you did from the first cranial, and I also show the parents. And about 1/3 of those kids, they don't come back for that. About another 1/3, I need the parents to do this every now and then to keep the problem at bay until the kid gets a little bit older. About 5 or 6, the orientation is posterior lateral. And in another 1/3 I've seen, I do my thing, I show the parents, no changes. But if you're doing this, you better tell the parent. I've had the parent say, what procedure have they gotten done from the ENT? The tubes, okay? They call it myringotomy. So they puncture a hole through the membrane. They put a little tube through here, they punch a hole through it, trying to equalize the pressure. And they say, I've had parents ask me, will this affect the tubes? What you're going to do? Yep, they might fall out. You better say it. The words better come out of your mouth. Yeah. Because number one, the tubes fall out anyway. They come out frequently anyway. But you may actually be the cause of it. Just understand that they are there in your office because they have tubes in their ears and they still have the problem. So I don't want to hear it and I don't want to be blamed. Yes, the tubes are maybe going to fall out from what I do, of the unsuccessful surgery that you're worried that I'm going to mess up. Okay, and it's your choice. You want to go forward or not. Okay. And I think I showed you this video, so I won't show it again. But this is a little boy I treated who wasn't breathing well, and I showed you that already, so I'm not going to show it to you again. Jun, yeah. Well, I'll skip
Can I
it.
ask a question from the start of it?
Yeah.
For babies that have feeding tubes, 2-year-old baby
Mhm.
that won't suck, that has constipation and so forth, does the baby eventually start looking at his brothers and sisters and start sucking, or is it something that you need to treat, or?
I don't know how to answer that first part, you know, where they look at them and start doing that. I've had kids that were on feeding tubes that weren't able to, that have treated, go back to the MD, the person who put the tube in, the person who's going to make the decision of whether or not to try and take it out and see whether they can start feeding. So, yes, in some cases been successful, no in some cases. My role is this, you know, I have this little area that's my domain. I don't look to, you got an MD taking care of something, ultimately they got to go back to them and get them off it. I do have a luxury, and that is because I can prescribe medications of being able to pull people off. But to be sane about it and to not spend my life defending myself, if you're on neuroleptics, which I think are, let me say this one part and then we'll just we're done with that lecture, we'll take a break. Neuroleptics, I think they're poison if you don't need them. Neuroleptics are a soup du jour that's been popular for 20 years, which are seizure drugs, anti-seizure drugs. The idea with an anti-seizure drug, it used to be, you know, old ones, Depakote, Tegretol, Phenytoin. These are the old ones. The new ones are Lyrica. Okay, they're spending billions of dollars telling us how Lyrica is better living through Lyrica. Okay, these are all neuroleptics, and the idea of a neuroleptic is this: you have some problem, and the nerve is being stimulated too much, so we're going to blunt the nerve. Okay, so we're going to make it so the nerve can't get stimulated so easily. That's how you attack seizures. You know, the old idea of, you know, the epileptic seizure, we give you neuroleptics. You need neuroleptics, okay, because you can't live with seizures. So we raise the threshold for stimulation to the point where you no longer have seizure activity. When I was graduating medical school, these were starting to be played with for pain. That if we do that enough, it'll block pain. The common sequela of taking a neuroleptic, the common side effects are going to be two really distasteful side effects. What do you think they are?
Lack of sensation in general.
Lack of what?
Lack of sensation in general.
Well, you know, it's gonna be a little, yeah. You gotta,
That's decreasing.
you know, decrease your life, and you gotta blunt everything. Because we don't have any magic pills that just do this. You know, yeah, I'm on Lyrica. It's really changed my life. So is that, if I'm going to block your neurons, I'm going to block all your neurons. Okay? So lethargy and just taking it out of you. You're not going to be you anymore. That's one, and the other one is gaining about 1,000 pounds. So whatever problem you had, I had one patient with 3 cervical herniations, 4 lumbar herniations, and yes, she had all these problems, and everybody was seeking, trying to do whatever for her. But adding another 100 pounds in weight in her actually didn't help the 7 herniations. A 16-year-old girl put on Toprol for severe headaches. Okay, and a 16-year-old girl put on about 75 pounds. So we can go into all the social side effects of whatever. 16 years old, came to me on toxic doses of Toprol. Now, when her headaches, I never made them go away, but I got it from 4 hospitalizations a year to no hospitalizations, and to, on her scale, a 2 or 3. I can live with this. Now, I want her off the Toprol, but I won't be responsible for it. Back to the neurologist, don't think you need it. They started taking out, what happened to her? She got blue vision. And that may be permanent, but in her case, it lasted about 6 or 9 months. You can read it right on the box. It's a possible side effect of going off that medication. She started seeing everything like she's wearing blue filtered sunglasses. So, you know, these medications are scary. And I'm not the anti-medicine guy. If you're having a heart attack, if you're having seizures, you're going to swallow your tongue, yeah, we need to do something for you. If you're thinking of killing yourself, yeah, I'm going to give you some sort of anxiolytic until you can't move and intervene in that moment, and so we can try and help you so you don't kill yourself. But I think about it. I think about it before you do it. And I'm not saying doctors don't care. They're just, we're given a menu in medical school, you know. Here's the menu for this problem, here's the menu for that problem. So they're doing what they've been told to do. And they do have a lot of political push telling them, Lyrica is going to make your guys happier, John. Unfortunately, I joined medicine when there wasn't the financial inducement. Give everybody Lyrica. We're going to send you to Hawaii for a vacation, you and your wife. Well, I think Lyrica is a really good drug. All I got was crappy pencils and, and all the money was gone. So, anyway, that's the story on that. What's the purpose of your sinuses? Well, what we were told was that if sinuses moisten the air, filters things through your mucous membrane, also known as boogies. Your immune system, you have more IgA, you have a lot of IgA immunoglobulins in that filter in your nose. And dentition. Yes?
Which handout?
This is cranial, this is intraoral 2. Intraoral 2. No, I changed it. I forgot to. No, we're on intraoral 2. Okay. We're on here. I put the wrong one on. Part 2 for the French in the room. Okay, so this is what I was told. I just have to give you this history. In the Cranial Academy, we learned that the sinuses are these like little light areas of your skull, airy areas. Some of us have more air in our heads than others. I'll just leave it at that. And I was taking a class in 1997 with a friend of mine who, sadly, I think he could be actually smarter than me. Not sure, but I think so. And so while we're listening to this lecture on the sinus bones being light to make the head lighter, this is what was been said. It's just pablum that they've been saying forever. And my friend said, that's the stupidest thing I ever heard. I'm like, hey, shut up. I'm going to hear you, Talk at the bar later. So he goes off, he's drawn on a bar napkin, or drawn on a napkin, and he comes back and says, that's the dumbest thing I've ever heard. And so what I'm going to give you, my presentation comes from a friend of mine named Matt Dubrow, who I think will never get credit. And I've since seen the Cranial Academy change their tune and incorporate this idea. It's really funny, because I never heard it up until my friend talked about it in 97, and then he worked up a whole presentation that he did for a group I got together for him on dentition. And it's absolutely brilliant. Sometimes you think anatomy's been done and science has been done. Everyone should understand it already. And I never heard it before Matthew Dubrow, and that was dentition. If you didn't have, if you weren't a meat eater, you wouldn't need the sinuses that you need. And if you didn't have sinuses, you wouldn't be able to be a meat eater or crunch on things without having a constant headache. If I don't get a movie reference somewhere, it's not me. When you chew, okay, I pulled out this statistic from dental references. It's about 500 foot-pounds per square inch on your back molars for a few hundredths of a second when you're chewing down hard on something. Think about that for a second. 500 foot-pounds, even if it's just for a fraction of a second. If we did that to your tib or your fib and just put that kind of pressure on, off eating, your leg would be ground to dust. You wouldn't be able to have that kind of pressure. So Marissa, I ask you, how is it that you can eat and your head doesn't implode?
I guess it's the sinuses.
Thank you. You're getting all red. Did I just embarrass you?
Right now.
That statement is out there. Nothing we can do about it.
Now you're definitely
did it.
I think you were always hot, but that's just my opinion. Okay. So anyway, so how do these forces get absorbed in the jaw? They don't get absorbed. They have to transfer. What I told you about that guy who got it's called a contre-coup injury. Somebody threw a softball and he happened to be right there. Okay, and he had suffered no injury, no fracture to where he took the softball on the side of his head and it blew out the ossicles, 2 of the 3, I forget which ones, but it blew out his bones on this side of his head. It all has to do with transference of force. If the force transfers, you don't have the injury. So I took my friend, he did an absolutely brilliant lecture that I'm incapable of doing of comparative anatomy and architecture, and I just reduced it down to a few slides. This was a church around 1216. This was the way they did architecture. The church halls were limited. Do you know what the limiting reagent was about how big you could make that meeting hall? Do you know what limited it with the way they did architecture? The roof. Because if you're gonna build this way, there's a certain amount of way that you can support that until eventually the weight of the roof is just gonna collapse upon itself. And they didn't understand enough about architecture to create it. So when they started making this idea of an arch, then they were able to make grand halls. And it's quite unbelievable what you can do with an arch. Essentially what I just did here is just playing with the numbers. If you take an arch in a perfect world and we just take 500 foot-pounds, we only have to go through arch upon arch upon arch before we get to relatively nothing. Okay, so if I go through this and I go through 8 more, I don't know actually what the number would be, but you can get to a negligible force. When I was little and stupid, now I'm just old and stupid, but when I was little and stupid, my sister told me, take this paper and fold it in half, 32 times, and I tried, right? You go to 1, 2, 3, 4, 5, and then that's it. Because if you fold this like 32 times, it's going to go from here to the moon, right, exponentially. Well, if we do the same thing by taking a force and having it go into a pyramid, we're going to diffract it in a perfect world. We're going to diffract it and cut it in half every time it hits that kind of structure. So we only have to go through a few pyramids for you to take a massive force and for it to be negligible. And that's because of your sinuses. Your sinuses are effectively, I don't know how well it shows up on this, but it's just a series of pockets and honeycombs that are going to function like an arch. I don't have the comparative anatomy portion that my friend did, but he compared lions and tigers.
Hyenas.
It's a hyena, or there's some animal that's able to just like
Tasmanian devil.
Huh?
Tasmanian devil.
There's some animal that can eat, if stones happen to be in the food that it's eating, it just smashes the stones to bits. And it's not that your teeth won't break because of the stones, it's because the forces get diffracted. So he compared that with herbivores that have almost no sinuses at all.
Is that Shrek? Think that animal?
Can't tell you on that, but I know we have a bar appointment later. I think we can, the true answers will come then, or at least we'll believe we have the true answers at that time.
Liquid medicine.
So your sinuses, you have 5 areas that we could call sinus areas of your skull. So what are they? You have your maxillary, your frontal. Frontals are actually quite large. You have ethmoid. Where else do you have? Your sphenoid has a sinus, has a big sinus. Okay, back here, and it's all going to be diffracted when you eat. And then you have a 5th area. No sinus here? Well, we have things that we call sinus, but bony sinuses. Where else do you have a 5th bony sinus?
Right.
Where?
Eyes.
No, not your eyes. Frontal, ethmoid, maxillary, sphenoidal, and then one that they used to drill out if you had chronic ear problems. They used to do a roto-rooter. Your mastoid. This is actually, we won't call it a sinus, but in your mastoid process, they're bony air cells. I saw a very young girl, 7 or 8, who they said she had got a mastoiditis, and they did what they did in the 1930s, which is just take an egg beater and go there and drill out the air cells. And that was a kid who had vertigo and all kinds of problems that were really iatrogenic from doing that procedure. Of course, not fair for me to criticize them, because maybe she really did have a mastoiditis, who knows. And I was able to help her somewhat. So you have these areas of your bone that are sinuses, which means they are air pockets. They're not meant for exchange, which is what we're told, that they're meant for air exchange and cleaning things. Just none of that. It's all related to your ability to eat. You do have air that exchanges in there, but not much. Not much. You have a lot of innervation in that mucosa. When people have a sinus complaint, there's a routine that I do. There's not too many things that for me are routine, but for sinuses is one. I'm still going to do my cranial, my whole body evaluation. I'm going to look for where I think the key lesion is. But I'm going to do a couple techniques that I'm going to show you only if you have a sinus complaint. And I'm also going to follow that up with a lymphatic treatment, because I think that puts some suction on the engine and it's going to get things moving. Who was I talking with? Was it John? Are you John? John Martin. I call you Martin. Which do you go by?
Either one.
Okay.
My first name is Jonathan or John.
Which do you like? It's an either. I like Martin. It's just cool. Yeah. Okay. So was it you telling me you were putting the cotton-tipped applicators or Ray? Yeah. So what we did, one of the things that we did for sciences back in medical school is our teacher would take like a 6-inch the doctor Q-tip, which is about 6 inches long. We put it in lidocaine, which will numb things, and we poke it right back through your middle turbinate through the booger locker until there's like just a piece of wood sticking out. I used to hate doing it because it just skeeves me, which is a Philadelphia word. Just, okay. And we would put that in there and then just rotate the Q-tip around. What was the function of that for sinusitis? The function of it was just doing anything to stimulate the mucosa as close as you could to the turgopalatine ganglion. Also goes by the name sphenopalatine, turgopalatine. It's the same ganglion. The way nerves work is you do things to irritate them, and they send that irritation to other tissues. In the case of sinusitis, where they're clogged, they're runny, they're stuffy, we're going to make them worse to try and clean them out. So I don't like doing the cotton tipped applicator anymore, so I'm going to do some things to irritate the nerve down here. And when we do this on us in this room, many of you, it's going to burn. You're going to feel that. You're going to feel it go right up into your nose, into your eye. Some of you, you'll feel nothing. The patient who has a sinus problem, sinus complaint, they're all going to feel it. So you can tell them, this may be uncomfortable what I'm going to do to you now, but we're doing this to try and get everything watery and to get it running. Okay, we're going to try and stimulate this nerve. And the way we're going to do it is back here, this is another landmark we're going to find. We're going to find it on everybody. They're not going to be symmetrical. This foramen here, this greater palatine foramen, we're going to go around back where the back tooth is. Our landmarks is the crus. Keep in mind, my finger is like this. This is my finger pad. I come over here, and once I go over this bump, I'm going to go in. There's a little deviation where you can drop your finger in a little bit, or in my case, I'll use the edge of my finger. And one will be more shallow than another, but they're both the turgopalatine ganglion. What I'm going to use is mild to moderate. It's not going to be small at all. I'm just going to make circles. Doesn't matter which way you go. Doesn't matter if you want to rub back and forth. It really wouldn't matter. But I just make circles over that, pressing in and around the hole. And I'll do about 30 seconds each side. And that's all it's going to take to get their eyes are going to get red, the tears are going to come, and it's going to water up all the tissues.
That's the greater palatine foramen, and
Yes.
you're stimulating the which nerve?
It's going to. I'm only going to be about a centimeter and
Palatine ganglion.
I'm only going to be a centimeter and a half from that ganglion. Separating your mind, looking at these anatomy pictures like we have a lot of real estate here. We don't. My finger's going to be here, and I'm going to be here.
The trigeminal nerve ring.
Yep. But this is what's going to cause all the tissues to water up. So maybe there's another way we could stimulate the trigeminal nerve, but this or sticking something in the nose hole and turning it around, all those are good ideas. This is easy to do. So let's start with this first. Let me have anyone at this table and hit our gloves again. Okay, here we go. Landmarks are easy. It's going to open, relax, just relax. Open your mouth, stick your tongue out. Okay, just relax, do nothing. You have to do a little bit of misdirection to get people's tongue out of the way. I got a big finger and I have not much space in here. Now I'm right in the foramen. Once you go past the crus, the cross, once you go onto palatine bone, it's right there. I'm turning my finger sideways so I can just get the little nub of my finger. If I have an extra hand, which I usually do have an extra hand, I'll just do a frontal lift. Now I'm putting about moderate pressure. It's not light at all. I'm just rubbing on the mucosa.
Looks like it's pretty close to the last tooth.
Yeah, it's usually right across from the last molar. It may have been removed.
So we would use our index finger.
Use whatever you want. It doesn't matter. I'm just so used to using, this is usually what works for me. Pinky's not long enough. Middle finger has some bad connotation to it. Pointer finger is uncomfortable. I don't know. Just use whatever finger you want. Doesn't matter what direction you go. I'm going to go right over to the other side. Her tongue's starting to push me out a little bit. Relax. This side is much more shallow. The other side was deeper. Here's the foramen right here. It's moderate pressure I'm using. It's not light.
Is there a contraindication for this? Wisdom teeth?
I'm trying to think. If somebody comes to me with a sinus complaint, I can't think of why I wouldn't do this. I'm sure there is a contraindication if they have some appliance. Whenever someone tells me I got some appliance, I have this, I have that, I'm worried about it. I'm like, well, I don't know if that's going to shift for me doing it, so you decide. I don't pull on people's teeth. I will do a release around the alveolar processes sometimes, but but you may cause something to erupt that wasn't going to erupt. On rare occasion, you get an impacted molar that is now going to start to disimpact from what you do. The easiest thing is to say, I'm going to do this, there might be some changes.
I
How's that?
expected that to really hurt, and it felt kind of nice, like,
You know what I know about our relationship together? Is that I'm incapable of injuring you. But I think it's not reciprocal. I think you could probably really hurt me. So that's not a surprise. It doesn't hurt you, bother you at all. Because this burns. I have it done to me. It just burns. But I had some oral maxillary surgery anyway, so nothing's right anymore.
the stimulation felt good. Like, oh, this area needs this.
Okay. There we go.
Are your sinuses
Is it very obvious when you reach the?
Yep.
It's big enough.
On one side it'll be obvious, on another side it might feel shallow. You don't have much choices. Once you cross this, and most of your fingers are going to be smaller than mine, and you'll find it easier than me, I think. Once you cross this, go back toward the teeth. That's it. There's something that presses in a little bit, and that's all it can be. Because further back here is the choana. If you go further against this foramen is bounded by the pterygoid plates, which we're actually going to go. We're going to go behind the pterygoid plate. That's going to be a good time. That's going to be a great time. Okay, so you're bounded by everything here. Last tooth. Once you cross this, you're there. It's not that bad. Okay, so yes.
Are you bouncing or are you holding a
No,
steady pressure?
this is what I'm doing. Making a circle.
With pressure?
Yep, a lot. And she can tell you, well,
Constant
it feels
pressure,
pleasant to her, but
not bouncing. Constant
not
pressure
bouncing.
and then a certain light pressure.
you know I'm doing
It's not
something.
light. You know
You know I'm
something's
doing
going
something.
on.
It's not that I'm just waiting. It's not I don't know. It's not a pound of pressure, but it's probably a quarter pound or maybe getting closer to a half a pound. I don't know. There's nothing pokey about it. I'm not doing this. I'm going to
Okay.
do that in a minute after I get everything, after I get the waterworks started. Okay. So try it.
It
Let's try
felt more tender on the shallow side.
Pardon me?
It felt more tender on the
Okay.
shallow side. I don't know if that's normal or not.
It's hard to say.
Who knows?
What my goal is something that's when I'm doing this to people, it's mostly the complaint is this: you're burning. They're going to feel burning. Things are starting to run. If they have a sinus problem, it's a messy area. Someone asked me yesterday, do I do anything for the nose? I do it for sinus problems. People don't like grabbing their nose, and the sinus patient, the nose is not a pretty place. This is the only time that I'm doing something for the nose. I'm going to grab right on the anterior medial alar cartilage and unwind. And this is something I get asked a lot about. Can you do manipulation to yourself? Blah blah blah. My thought is, you have a problem. It's just so much better finding somebody and getting on their table. You have no objectivity. But when I've had my own sinus issues on occasion, more in my case, it's just reacting to whatever's in my environment. Because I'm always in a different environment. This is something you can do. Of course, don't let people see you do that on an airplane, because then they will think, it wasn't a pick. It wasn't a pick. Okay. So
Seinfeld.
yeah. So I grab under here, pinch it between whatever fingers you want, and unwind it. I'll take it whichever way, and I'm just unwinding it in a circular fashion. If you make the longitudinal axis, I'm just going to crank it around. Whichever way, I'm going to be able to get more distance. So I'm going to take it indirectly, but really, it won't matter whether you go direct or indirect in my mind, but I end up doing it indirectly. I'm just going to crank it around, and not back and forth. I'm not indicating that. Just one way and hold it. Okay, and eventually it's going to help them start running as well.
I don't quite understand.
Yeah, what are we doing?
You're going to grab under the nose hole. Okay,
This
but
was the
you're
center
grabbing
one or
you're going to grab the nares. Okay, but you're grabbing the alar cartilage.
Got it.
Okay, which is in the front here. Okay, so you're going to pinch it with your fingers. And I got big fat fingers, so I'm going to use just the end of my fingers, and then I'm going to twist it one way and hold it for about 30 seconds is a good amount of time. What I want to do, it's going to further get all the tissues starting to run before we pump the sinuses.
You're not going deep in there, you're just right.
Nope, I don't want to go deep in there.
Downtown.
Not going downtown. Okay, just right at the surface. So let me have somebody lay down. Yeah, not all at once. You're volunteered for this one, huh?
You're welcome. Very welcome.
No one likes this.
They like it because it's taking the finger all the way up there.
You got that right. I'm not going to wet the glove. Don't need to. So I'm going to use my smaller fingers. Can't really use my pinky finger too well. So I'm going to grab inside and grab as much of this cartilage as I can.
You just go in the direction of tension.
Yeah, I'm going to go. It doesn't matter which way I'm going to choose whichever way I can keep a hold. I'm slipping off is the problem.
Are you on one side?
I'm on one side. I'm going to do both sides.
At a time?
Did you wet your finger?
Yeah.
No, because I don't want to wet my finger because it'll just make me slip more.
What direction are you making?
The easiest.
Rotating towards me. Shall we say it's just a weird feeling? I have to grip hard enough so I don't come off, but I don't want to grip too hard that my grip's uncomfortable.
Does the end feel like
It feels like
the ear?
it feels like it just starts to loosen a little bit. It doesn't get ooey gooey loosening, but it's just the grip loosens. You just gotta make sure your grip is loosening and you're not sliding. That's the problem.
Why don't you grab more of the cartilage?
Grabbing as much as I can, short
Because
of.
your fingers.
Yeah.
Okay.
And you
Would it
grab
matter
right
if you
below the
grab
bone?
more?
The cartilage is right here, the alar cartilage. So going all the way up, I don't know what that will do.
How do you decide what direction you're going?
I'm gonna go where the most resistance is and just take it as far as I can.
Most resistance is
Yeah.
direct.
Yeah, but I was taught you can do it direct, indirect. Whatever it is, you're gonna take it to the max that you can,
So you're really like
short of making it a rhinoplasty.
moving it around.
She'll tell you.
Tell us.
I can breathe a whole lot better, I'll tell you that.
Me too.
What is the question?
How hard is he pulling on you?
Is it close to the white light?
It's not as hard as my kids would pull on me.
The question
It
is,
feels therapeutic.
Your kids put their finger in your nose and pull?
kids put everything in their nose.
No, her nose.
It's common property.
So you're rotating in the same direction on both then?
No.
I'm not choosing, it's just, this feels like I'm getting more resistance this way. The real question is, how many licks does it take to get to the center of a Tootsie Roll Tootsie Pop? That's right, it's 3. Those of you who remember that, the owl. 1, 2, 3. Crunch. 1960s were a good time. How can you even know that? You must have watched it like Nickelodeon at night.
73. It's in the 70s.
Was it? We're still doing that? You remember Choo Choo Charlie?
Yeah.
Remember the Frito Bandito?
I am definitely the bandito.
Yeah, that's racist.
Frito Bandito?
Yeah.
I didn't intend any racism. Just wanted the damn chips, really.
But that's why they took it off.
And we got a little toy once, the eraser Frito Bandito guy put on the end of your pencil. And my sister got all the toys. Because she's 5 years older than me, so she beat the crap out of me. And any cereal that I liked, she took the toy out first. That's just wrong. Yeah, that's just wrong. That's why I am the way I am. Reach in my hand in the box, get the toy, it's been ganked already. That's just wrong. You can see your nose is red. It sounds like there's some noise going on there. And your sinus patient, that's who I'm doing this to. I'm not doing it to anybody else that's not having that problem. And my goal with these 2 techniques is to just get the waterworks started more, and then we're going to do a pumping thing. Okay. I'm doing this for science people. I'm doing it to get the water going. We'll see the water in their eyes. Some of you already on the table. We'll see the water in the nose. More importantly, I want all these membranes behind here, mucous membranes, trying to get those to get a little bit engorged with more water, which is also going to be more mucus. More stuff is going to run. The one consistent thing that I've seen when I've gone and done it and your partner's done it is you've been too light. So for this thing, we're going around the greater palatine framing or working on the nose, don't think light at all. You're gonna put a lot of pressure, and then you're gonna use a lot of crank on that. Well, not crank methamphetamine, but you're gonna crank it around. Okay? Then I'm gonna do some pumping. This maybe I'll spend a minute in total doing pumping. One, I'm gonna start right where we started as far as doing mobilization. Now I'm staying there, I'm trying to get as much movement as I can. And I'm gonna do it a little bit more vigorously. Not a pound of force, but I'm just going on, off, having nothing to do with cranial rhythm at all. Just trying to compress the tissues a little bit, on, off. I'm gonna call this just a made-up name, frontoethmoid complex. So I'm going through this bone here and sort of aiming for the front part of their head. I want to put a little bit of force, a little bit of, what was the term that you used? Echo something.
Echolocation?
Yeah, I don't know if that's accurate, but I like it. Okay.
It's the feedback you give after
We'll work on this at lunch, this name.
Okay.
So we're going to echo something through here. Okay, I want to go from here, and I'm trying to go up here. Then from the same position, you have a very large sphenoid sinus, by the way. The sinuses are quite large. I'm going to just alter my direction, not my finger, because the size of my fingers, once I'm in this space, I'm staying in that space. Again, if you've done the first two techniques, you're doing this, it's just going to continue to run more. What else can I say? Okay, that's all I can say about that. Yeah.
So you're targeting frontal and then back to left sphenoid?
Yeah, I'm just targeting with my vector of force to go through the frontal ethmoid complex up here. Put a little bit of a shock wave through there for about 30 seconds. It's not a shock wave, it's just a series for about 30 seconds maybe. Plus or minus, you can always do it more time. And then here I'm just changing my vector. The same way we did the compression, decompression was into the sphenoid sinus. I'm trying to create a little bit of shock through there. And that's the
Can you step back just a little bit?
Stand back a little bit.
Sorry. Then that's the last thing that I'm doing, and I'm following up with a whole lymphatic treatment to sort of put it like a siphon on the whole system. And this,
What's the point of contact?
I'm going to be so limited. My finger, this is premaxilla here. Once I come back, I'm trying to avoid the teeth. The same spot that you were in the beginning for doing mobility of the vomer, that's where I'm going to be. I'm not actually moving it. I don't want to go past the cruise.
Is it the same vector as you're doing the compression?
Yes. Well, this is the compression, decompression, and this is what we did for the frontal bone. Same. So let me have somebody lay down. Anyone? This is pleasant. No, the nose stuff is weird. Here. Anyone? Head here. Head here. And I'm always with the extra hand doing a frontal lift. Open. Okay, close. Now with John, open again. I have a limited amount of space. The way his palatine is shaped is kind of like there's a big slope coming down to his premaxilla. So where my finger is now, I'm not touching the maxilla, but I don't have to go that far back before I hit the cruise here. So I have such a limited space. My finger fits in that spot, and that's it. If I bring it forward, I'm really on maxilla. I don't know if you get the.
I don't get it. What are you talking about?
Stay there. Let me have the.
There you go.
There we go.
That helps.
So this is not you, okay? His is more like this, not his teeth, but the maxilla. It's more of a slope like this. So for me to get back where I'm not actually touching maxilla, I'm further back in John, because I only have to go a little bit before I'm going off of maxilla. So you look at the photo, you look at the pictures, and you think you have a lot of land here. You don't. Some more than others, and depends on the size of your finger. So here, the vector is this way. It's just going to be up towards this finger here. I'm going to go up and up and up and up. The next one is just going to be down, down, down to the table. What if you're off by a little bit? It's okay. It's an imperfect world. Let your jaw close. Relax. So I'm going to move up here. I have my finger bent a little bit to avoid putting pressure on his maxilla. If you put pressure on his maxilla, it won't be the end of the world. If they have caps or dental work done, yeah, it could be the end of the world. It could be an expensive day for you. Okay, so I avoid teeth as much as possible. I haven't had a tooth fall out on me, but I've had friends who've told me that they've done something and tooths come loose.
This vector is more anterior than the very first.
It's right here. No, it's the same.
It's the same.
Same. Shades of gray. You know, maybe we could say something, but it's shades of gray.
Relative to the position for the vomitor, it's slightly more posterior, or
It's the same.
The vomer, you're adding another syllable in there. I thought it was my hearing. Saying like the vomner, but we give you a special dispensation because you've been in China too long. The vomner, as it's been known in New York, is above the intermaxillary suture. So I'm not actually getting it directly, just indirectly. But I can feel it's pressing on my finger up here. And then I'm going to change my direction, try not to put pressure on his teeth. Get your contact point first, and then on, off, on, off. But I'm not coming off of I'm not coming off of his mucosa. Not coming off the tissue.
So I'm not quite getting how this is different than what we did the first time.
It's not.
Oh,
But now you're doing it for about 30 seconds.
All right.
The compression, decompression, you need to just slowly wind your way into that tissue. You're taking the long road and compressing, and then the long, slow road coming out. Now I'm going on, off, on, off, on. There's nothing compressive or decompressive about it, actually. Because fascia needs a little bit of time to accommodate to your slow road in. You follow me?
On
Hold just stop for a second. Is that clear what I'm saying? If I'm not saying it clear, I want to say it so it's clear.
Sorry, mate?
Yeah.
I understand that
Okay.
what you're doing right now is faster than what we had been shown
very
as
fast.
far as the manipulation of the vomer
Yeah.
the first time, right? The first manipulation that you just showed us now pretty much seems like like the first manipulation
It
you
is.
showed us at class, but
Yeah.
just
That was my question.
slightly faster or not? Or
Very fast.
Very fast. Okay.
same
The first one I'm just doing a gentle on, letting it push me away, on, letting it push me. There's no letting it push me away.
That's
On,
very
off, on, off,
good.
on, off. And I know you get it, but maybe some other people are not getting it. When I'm doing this, hold on. When you're doing this compression, decompression, I need to slowly get there because I need the fascia to accommodate me as I'm getting there. That's completely different from poke, 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 which is what I'm doing.
For lymphatic.
But as I'm doing poke, 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 I'm never leaving the skin and poking. I'm staying on. Okay.
Back and continue. Anybody have any questions? Like we had, why would you do this to get the waterworks running when the person's waterworks are running already?
Because I want them running more.
Even if that's their complaint,
The complaint isn't the waterworks, the complaint is that it's not stopping. It's a non-stop problem with them. So if I can make it worse before it gets better, it's okay. And there's other areas where, I'm trying to think, there's other areas where we do that to exacerbate problems or to activate the body's healing mechanisms. We do that with sclerotherapy, old word for prolotherapy today. And it's if when ligaments are destroyed, we inject an irritant to cause the body to proliferate. Okay, well I don't know TCM, but I was in one office where they was injecting pumice into someone's SI joint. Pumice, and it's just what you think it is, volcanic rock. And I said to the guy, I go, well, how's that stay in solution? And he pulled out this, I don't know where you even get it from. Okay, he had it in solution. It's just like a bunch of dust in the bottom of a bottle. You gotta go like this and then draw it up all like that. Stick it in the guy's SI joint, and the guy's writhing in pain, like for 2 hours. There's no way I'm doing that.
wow.
I was comfortable using some different solutions and things, but that's a little bit gamey even for me.
Protein being one of the parts in it.
Well, protein's going to be in it anyway, but still, it's such pain. Such pain. I used to use, when I would do injections, I used bupivacaine, Marcaine. Procaine lasts about 20 minutes, 30 minutes. Marcaine will last about 6 hours. But still, if you're feeling better, next time I saw you, it's not because of any anesthetic, it's because of what you put where. But so, yeah, I'm trying to get all the waterworks running and trying to maximize it. And then I'm also going to follow this up with lymphatic stuff. That's not what we're doing this weekend, but the whole process to get things moving. And I have much more success if I get a little bit of a histamine release and get things a little bit more edematous. Zygoma. Facial bone motion generally thought to be secondary to sphenobasolar motion. The whole face, we think of it as being secondary to that. We're not really thinking of treating it as a primary dysfunction. I'm not. I'm going to show you some invasive things to do for the zygoma and something really easy that I thought was a waste of time that ended up being useful for me. When I found it useful to do a zygomatic treatment, I don't do it as part of a cranial protocol cranial protocol for me, and maybe that's the wrong word, is I know at some point I'm looking at all the vault bones, and I'm going to try and release them. I've given you what the Cranial Academy gives me is occipital bone should cause that problem, temporal problem should cause you being dizzy, blah, blah, blah. That has some value to it. But truly, the temporal bone has to move against all these other bones. There isn't a temporal bone problem. There's a cranial vault that should be addressed. Maybe focused on the temporal bone, but I think you need to address the whole vault. At least for a nanosecond, get your hands on each bone and go. I don't feel that way about the face at all. So when I've worked on zygoma, for me, what's been outstanding is usually a tripod fracture. Tripod fracture is because a tripod here, when the way your zygoma comes out from the ridge, from the maxilla and down from across the nose. And usually a tripod fracture is usually associated with a knuckle and alcohol and your mouth. Okay, so that's when I've seen it, or it's been a car crash and someone's gone through the window with their face. So that's when I've had to dig out the zygoma techniques. And okay, that's when I've had to dig them out. So that, all right, gotta slow my brain down. It's a paired bone. So what do paired bones do? Internal and external rotation. Essentially, it's this. You can add some little other kind of motions that might be occurring to your head, but the general thought is it's this. We can put our hands across the zygoma and we can follow that motion. And I thought that doing that would be perfectly, exactly pointless until I had a headache patient who had flown through a windshield in a high velocity car crash. She looked normal to me, but she showed me a picture of what I used to look like, and after they reconstructed her face, and it wasn't the same face. But she looked normal to me. So the complaint, what's the complaint? Headache, face pain. I did all the cranial stuff there, a whole lot of nothing. The treatment or two, and I felt everything else was okay. I want to put my hands across the zygoma and just waste my time here. I can't think of anything else to fill time. And I just was following the motion. Pain gone, problem solved, end of story. Previous to that, you would have never talked to me in that technique would actually do something. And I tried all the pushing and pulling. So we'll do something really easy for that, and we'll do something a little bit more complicated. The complicated one, we'll start with that first, zygoma and pterygoid. Well, let me just... Yeah, let's do this together. So we learned this as a zygoma lift. Okay, I'm going to do three things together. Let me do it all. Just do it all and put it together. Just do it all. Okay. So we'll work on the motility. We'll do a zygoma lift. I'm going to do it the way I was shown in school. And that is, I can't really show it with the arrows. I don't know a right way to do it. But I'm going to take a finger and I'm going to go around this last molar. I'm going to ask the patient to open big. I'm going to put my finger around, and you already see I got sausages, so that's going to be a problem for a lot of you. I'm not going to be able to do it. Try and get around the last molar. You're going to have them bite down. If you can get behind the last molar and they're going to gum you with the condyle, it's beneficial because they can control the level of pain. It's going to be painful. For some of you, you're going to get a headache. For some of you, it might be some other pain or somatoemotional releases or whatever's about to happen for you, but you're going to be responsible, not me. Because the finger's there and you decide how hard you're going to bite. Once you're in that space, ask them to begin biting down as much as they can tolerate. Maintain the pressure for about 30 seconds. It's important that the pressure is consistent, that they're not on-off pressure, on-off pressure. And they don't have to be all or nothing. Just ask them to bite down, and just hold it. Okay? You may or may not repeat it. We learned it as a lift. It is going to lift this area here, but it's also going to stretch the pterygoids. And then it occurred to me that I think this is more useful effect in the pterygoids than it is for the zygoma, really. So I started doing it another way that I'll show with you.
So the pterygoid is going to hit your finger that's in the way, and it's going to stretch that pterygoid.
It's going to stretch it, yeah.
Contact.
And I'm going to show you in a different way. That because I can't do this on most of you. Either the last tooth is there and I can't get around, or the tooth isn't there and I'm trying to put a hot dog between your teeth. So
use a pinky.
I usually can't get in that far.
Okay.
But I'm going to show you another way that works for me better. But let's do this first. So let me have someone lay down here. Head here. First, we're going to do this. just motility of the zygoma. This is what I did for this lady, and I've done subsequently. If you've had a tripod fracture, your face was reconstructed, this isn't going to be the one and done technique. I still went around the vault, I still released it. I'm pretty sure, I don't remember, but I'm pretty sure I did intraoral on her. What I remember is using all the tools and going nowhere, complaining exactly the same. And then if I want to be only on zygoma, I'm going to put all my fingers together like this. I can try and go like this. I'm going to be on the frontal bone as well, but I just happen to like doing this. I'm going to support my elbows on here, because otherwise I can't. If I'm doing this out in space, I'm too concerned about keeping my shoulders up. So try and be as much on just that tripod as you can, and just let it go through its internal and external rotation. This is internal rotation, which it should be doing as the rest of the body is going into extension. And I'm following cranial rhythm. It's not mobility at all. Not mobility at all. You can follow them to the end of internal or external rotation. Hold it for a little bit. Relax, and then they should go through an increased amplitude. It should feel pleasant. It should feel like nothing. I find it really pleasant following people's rhythm for the most part. My experience of it. How's that?
Pleasant.
Pleasant. See, that's the word. That's really what it is. Pleasant. Okay? Sometimes people don't like you going across their eyeballs. We're going to do some things to the eyeballs also today. I find I have more control doing it this way. But, you know, don't be holding your face like this, because then you're all over the place. This is not a zygoma technique. The zygoma is far out from your face. I mean, it's far away from the SBS, so you can feel a lot of motion here.
Do you give a little bit of, like, lift?
I'm not.
But it feels
But I don't
like
think-
tentacles.
Gecko fingers.
But I don't think there's any reason why you couldn't.
Okay.
You know, when you do a frontal lift, frontal bone, we learn it as flexion extension, and that there's some element of internal and external rotation because of the metopic suture. And I don't find that to be, you know, you find things that you learn and teachers talk about, and then you find a patient where it becomes relevant. I never found this to be too much relevant until I had a guy who had his face crushed in here. I don't know what else was involved in it, but there was brass knuckles on the other end involved in it, and his head was reconstructed. And he had hypermobility of this. I would think it would be hypomobile. I would think it would be glued to the rest of his head from that. But no, it's hypermobile. At least rhythmically, that's what it felt like. I do things to people. You working on anybody with plates in their heads? Paige, you must be.
One client.
No? I found plates to be interesting. You know, sometimes the plate, you obviously feel like there's something else there that's stopping the movement, and sometimes you're just feeling rhythm going right through the plate. So we're going to do that. That's just going to be easy. Now let's do something less comfortable, shall we?
Yes.
Let me try one. I'm going to need the whole gloves. This is going to be a sloppy procedure. Anybody like horror movies in here?
Oh my gosh.
Do you? No, this is going to be a love story, not a horror movie. Does anybody like horror movies?
Uncomfortable.
Cabin in the Woods was pretty good.
No one?
That's-
Not
that's
one
a funny
person?
one.
I knew you would. We're brothers. Pinhead
A
is one of my
good one.
favorites from Hellraiser. Pinhead.
Zippy.
No, Pinhead. Oh, Kirsty. We have such sights to show you. Get to see Hellraiser, and then it all makes sense. Or not. Or not. Okay, here's what I'm going to do. I want to go around that spot. Okay, and the way I was taught, I can't even, I'm going to show you, but it's going to be impossible for me to do.
Skeleton after you're done?
Yeah, okay. I was told to bend this knuckle in like this and get that into her mouth and then open the finger so that I'm not dragging her cheek in. Open your mouth. Because if I try and go back in, a lot of times you're going to just take this finger and you're sucking their cheek in. But if I put my knuckle in up there and then I open my finger, I'm going to hit the back of her throat, and then she's going to be really uncomfortable. So right now I'm not having to do that. I want to get in the space back here, and I can. Okay? Now you're going to start to close, open, close, 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 close. Okay, her I can do it. Now you're going to increase the pressure. Just keep bringing pressure. Close, close more. You're not hurting me at all. Close, close more. You're not hurting me. Not hurting me. Just keep the pressure constant. Don't go on off. Keep the pressure constant. So she's going to do the work herself. She's going to stretch her pterygoids. It's going to indirectly lift the zygoma, a little bit cephalad. She's putting a lot of pressure on my finger, but she's not hurting me. So you have to walk them through it because they won't want to bite on you.
And what's your direction with your finger?
I have no direction. My finger's going like this. I'm not putting any pressure. She's doing all the work herself.
You're outside
It's
the
behind
teeth.
her molars and
I am
Yeah,
between
that's what
her
he
teeth and her cheek.
Against
Okay,
the
open.
pterygoid?
The pterygoid's going to be behind me here. Okay, so I'm going around her cheek and to that space. If you take your finger, stick it in your mouth, go along your cheek, and go behind the last tooth. That's what I'm doing.
That's
Okay?
what clamps down on your finger.
And you can see she did put a rather nice bite mark into me. It'll probably go away. My lawyer will be in touch. So, she's not hurting me as long as it's consistent. Some people you can't do it because the teeth are there and I can't get into that space. How's that feel?
Uncomfortable.
Well, it's your fault. You're the one who's biting down. I just put my finger there. Okay, so she can control it. Let's try that first, and I want to show you an adaptation that I was forced to make. Yes.
You're just doing constant pressure when you get there?
I'm not doing any pressure. I am doing placement. I'm making a fulcrum. And I'm making the fulcrum with...
Your finger is big.
Thank you. Thank you. So I'm putting a finger here, and she's biting down. There's nothing for me to do. I'm just placing my finger. What I don't want her to do is on-off, because it's painful, because it is uncomfortable. But who are you going to do this to? If you want just to be very specific, TMJ people, this is who you should be trying it on. Okay, or TMJ head related, or TMJ cervical related, cervical that won't release. You've done other techniques. It's a very good technique. It's going to, again, give a lot of information back to the cord. It'll override some things. You are going to stretch out your pterygoids, do your mashing like this. Masseter is kind of hard to work on. We can do counter strain to the masseter, but I think it's a limited value. Temporalis is hard to work on against the skull. The pterygoids, there's a few things we can do to them that we get immediate benefit. I never, ever, I try and address, my jaw is clicking, can you make the clicking go away? When they say that to me, my jaw is clicking, I go, are you having pain? Is it painful while you're eating? Are you having headaches? You know, that. Try and get those symptoms, write down as many symptoms as you can. That way you can go back to them after you've done a little bit of treatment. Is it as painful while you're eating? Are you doing this? Not the clicking. I don't know if the clicking will ever change. Okay, so again, I'm not going to do it to you again, but you're going to open. She's going to open. I'm going to go between her cheek and her teeth. You got to go okay, you can relax. I'm going to go all the way back and around. Okay, and she's going to essentially gum me if I can get behind it. If I can't, and she's got all her teeth and there's no space, I'm going to do it a different way. So first, do something. Try and feel the rhythm on the...
You're going to do the side?
Okay.
It feels lopsided.
I should put a glove on the other hand and do it the other way, but I'm right-handed, so I'm going to do it this way. Open. Now I'm starting to drag her cheek in because it's gotten a little dry. Okay. Open, close. Close. All right, hold it there. Just hold it there. That's enough.
Lift off.
Yeah, we have lift off. Make sure your tray tables are in the upright and locked position. Please bring your seats forward. And don't bite any harder. Just right there is good. Ease it up a little bit. Close down. Close down. That's good. Slightly ease back a little bit. That's good.
Feel the release to his
I'm I'm having a release right now. Okay, relax, open. I'm not sure what I must have done to you on the other side to get that reaction, but she didn't do it the same this one. There was just a jump in biting down. She bit down pretty hard. But it's okay, I asked her to do it. So we wanted to just smoothly do it. The pterygoids, this is not going to be a perfect situation. I'm going to have a huge finger taking up this space. So Ray's asked me, medial pterygoid versus lateral pterygoid. I'm putting a big hot dog back here, so it's going to indirectly stretch. They're both going to be affected. But is there another way that I can do this if I can't get in the space? What I'm going to do is I'm going to put my finger straight in, midline. I'm going towards that condylar process, but I'm not going to be, where's the jawbone? Okay. So what I'm going to do is open the mouth like this, and I'm going to, thank you. I'm going to go right where the teeth are until I hit, I'm not going to be on this bone. I'm going to be close to it, I'm going to be pushing on it, and there's a lot of tissue coming out at me and the attachments to the pterygoids. So I'm going to go straight in that V, and now I'm going to put pressure straight on. So she is not going to control the pressure. I'm in charge. Okay? So it's going to look like this, and this is much more easy for me to do. I'm going to use this hand on the outside of the cheek just as a guide, because here's the problem. I'm going to come right in at this V, and you can slip off, which is somewhat emotionally traumatic for people when your finger goes down their throat. So I'm going to use one, and that's not going to happen here. So I'm going to use one hand as a guide and go right on that V. And you're going to find that both sides are probably not going to be the same. Sometimes the top of that V feels like a plateau to me, and I'm just pushing with my finger and it's easy. And sometimes it feels like it's like I'm on top of a razor blade. So you're going to open. Okay. Now close, relax. Okay, now I'm right in where that V is, right on this fascial tissue, right over the muscle tissue. Now, when your hand goes up, I'm going to slow down. This I'm commonly doing. Okay, as part, we go back to what we did as far as roof of the mouth, we did vomer and maxilla and palatine. Then when I'm doing floor of the mouth, this I include with doing floor of the mouth. I do floor, I do tongue, and I do this. Okay, so open, close, okay, relax. Okay, here comes pressure. If that hand goes up, I'll slow down, okay? I'm going to bring her right to what she can stand. About 15 seconds is about all she's going to need. It's all that, right?
Yeah.
Yeah, but I'm watching her hand, I'm watching her face.
It was tolerable.
If it's not, you'll stop me.
Mm-hmm.
I hope to always catch them before they actually have to stop me. Because there's a little trust thing, like there is that subtle, why didn't you feel that? Why didn't you feel it was too much for me? So I try to catch it. I don't always catch it. And from here, I'm going to use the same finger, same hand. Okay, relax, let your jaw relax. Okay, here comes pressure. It's really nice. It's a quick release. It's not long. I'm not counting 30 seconds. I put pressure. There's nothing that feels good about it unless you're a masochist. And you feel this, and then it very quickly starts to fade away from you. As soon as I feel the fade, I'm done. And it's not fun, but it's tolerable. And it works. It works for releasing a lot of the tension out of the jaw. I throw this in here. It's really, we would talk about this in a counter strain course, but just to be complete. Just to be complete, as far as talking about the jaw, we can talk about doing a counter strain technique to the masseter. I'll mention it, demonstrate it. I haven't personally found it to be so useful in my practice. If you have TMJ problems, I'm doing the pterygoids, I'm doing the floor of the mouth, I'm doing the roof of the mouth. But as far as a counter strain technique, just to take a little short snapshot on it, we can go in the middle of the muscle belly for the masseter, have them open their jaw. I have them open their jaw, they're going to deviate to the ipsilateral side, same side as whatever problem you're working on. So if it's on the left side, open, bring it to the left, and then you're going to close. You're going to passively close their mouth for them. That's about all you can do. In a nutshell, counter strain is the idea of bringing origin to insertion to try and take tension off the muscle to reset the gamma gain. That's the short story on counter strain. But for me to do this, I don't have a lot to work with, because once you're having them open their jaw, deviate to, if I'm working on this side, deviate and close, you now have a malocclusion, so the origin insertion actually isn't coming out down as close as you'd like to because you have a malocclusion. Their teeth are keeping their jaw a little bit more open than it should be. So let me show you what that looks like. Okay, let's do these two together. We'll do this, and then once in a great while, I'll do something for the alveolar processes. Not usually. I like to leave that alone. I like to play with teeth, false teeth, caps. You know, if you've had a gazillion dollars worth of dental work done, and I was joking with somebody and told them what I've been through. Someone I was closely related to before, we spent $150,000 at the doctor's office, dentist's office. Not kidney either. Remortgaged the house. So I don't want to pull. I don't want an implant falling out of my hands. I don't want any kind of implant falling out of my hands. But if they're having pain around here, they had some dental work done, they got some swelling, take a finger, grab not the tooth, grab the alveolar process, which is what the tooth is hanging in. A slight bit of pressure and unwind it like you would a screw. Okay, you're not going up or down. You're just unwinding in a vertical plane this way. Take it to the position of ease and hold it, and that will do an amazing amount for people that are particularly sensitive, had a lot of work done. I don't see, for me, that's where my use has been. Let's see what else I got. Okay. All right, so let me do these two things. We have somebody here. Very, very easy. Just go back to sleep there. It is. Slide down just a smooch. Okay.
Do you have any caps?
I haven't had that happen, but I have friends who said they've, had a tooth come out or something fall out. Okay, so bite down, open, close. Okay, master's a pretty chunky muscle. If you want to decide, if she tells me I'm complaining I got pain on this side, that's how I would do it. I'm going to take this one because it feels a little tighter. I'm not saying it's dysfunctional. This feels a little tighter here. I'm going to go right in the middle of the muscle belly. I'm not going to go along the attachments, just right in the middle of the muscle belly. With my big fat finger, it does have a very bony end. So I'm going to try and find something that's a little uncomfortable with a little pressure. Is that uncomfortable at all? Not really. Are you sleeping or are you? Okay. Yeah, if it was uncomfortable, I guess you would tell me. Has anybody got any jaw problems, jaw pain?
Me. Hisham does.
Hisham, come here. Do you have it? Does that hurt at all?
No.
Okay, you're fired. Hisham?
The left EMG.
On the left side? Okay. Let's just try and see what I can find there. Slide down, slide down, slide down. That's good. Sorry, you now have like dust all over you, but you'll live.
Powder down.
Bite down, bite down. Okay, relax. Okay, relax. Does that bother at all? Are you also sleeping?
No.
Does it hurt?
No. Maybe a little.
Are you just saying that to be nice to me, or does it hurt?
Now it hurts.
Now it hurts, okay. I'm going to dig around the spot. I'm not trying to hurt you, but I want to try and find the most sensitive spot in here. Which is more? 1, 2? 1 or 2? I'm right in the middle of the muscle belly.
2.
Yes. Okay, does that bother a little bit right there?
No. Here you go.
No, here.
Yeah.
Okay. Now let your jaw open. Let me have your jaw. Do nothing with it. Do nothing with it. Relax. Do nothing. Move your jaw to the left, like that. Move your jaw to the left. That's it. Now relax. Do nothing.
It's hard to relax a jaw.
What's hurting? What I'm pushing? Okay. I don't feel much tension coming off. The book says we should wait for 90 seconds. My experience in counter strain is only ever waiting a few seconds, but this still feels tight to me. I'm causing him to have a malocclusion. Now I feel it easing up a tiny little bit. Stay here a little bit longer. Does it hurt now? What does that mean, what you just did?
No.
It doesn't
No,
hurt.
I'm out of here.
Okay. Relax. bring your jaw back. So I felt I got a little bit of reduction in tension of the muscle. Is it great standalone technique by itself? I don't feel it is, but it's something. A little snapshot of counter strain. So we can try that. Yes.
So are you move the jaw to the direction that you're working on, or the other way?
Yes.
Like trying to shorten the muscle.
The idea with counter strain is that you're bringing origin to insertion of muscles or ligaments.
Like the client's doing it? Or you're doing
No, I'm doing it. I have to get his participation though to deviate his jaw, because otherwise he's doing something different. But ultimately, I have to close it passively. And again, it's not standalone by itself. I don't know that's so great.
So that pressure is like trigger point therapy?
No, but we could do it. We learned in school that there's a Jones point, a trigger point, a Chapman's reflexes point, and that these are all 3 different entities. The Chapman's point is indicative of a visceral problem. A trigger point is something that creates pain in more than just its area. Either creates a radiation pattern of pain in that area bigger than it was, or it activates other types of points. And then a Jones point was just a tender point that was tender and only in that area. That's what we taught in school, and that's what we were examined on. My experience is it's bullshit. So you know that some of these definitions just fall apart. We've been taught by people as though this is black and this is white. You know, this is absolute. A tender point, I push on it and it hurts. We can make the argument that that's a trigger point, that it's causing some excessive radiation of pain. So I don't see the difference. With Chapman's points, which we'll talk about, I think I will do, I'll either do it in the advanced visceral or I'll just throw it into the lymphatics, but we'll talk about it because it's an important osteopathic concept. There are some points that people have found, and the MDs agree as well, that are reflexive of visceral disease. But I don't see these as all different entities. So let's just take a point that's painful or a point that's hypertonic. Pain or hypertonic. See if I can bring origin to insertion and change that response. Dr. Jones theorized after the experience of seeing the technique work. You know, you see the technique work, then you have to say, I'm going to teach other people how this works. Why is it working? So he theorized you were changing the gamma gain. Is what was being reset. Whether that's actually what's happening, I don't know. But you know, a lot of stuff gets told from person to person to person as to be true, and I don't really know. What we do know is the experience of watching either the pain go away or the tissue tension go away. So you asked me, is it trigger point therapy? I don't know. Maybe people would, in trigger point therapy, inject that and maybe you'll feel better. Yes?
So you're bringing his jaw into the direction that you're palpating and step on, or just into
Yes.
the...
First, yes. I'm bringing it ipsilateral. The idea is origin to insertion, and when I deviate his jaw to the side I'm working on, it's a little scooch closer than it was before, and then you're closing his jaw. My argument with that is this. When his jaw is fully closed, if we'd measured that distance between origin and insertion, I think it might be the same as when he's deviated and now has a malocclusion. Malocclusion is when your jaw doesn't close correctly. If I close it correctly, it's shut tighter than if my teeth are sticking out and I can't close them. So I don't know that the distance between origin and insertion has actually changed. This technique has some value. It only has some value in a bigger context of doing everything else to his head.
So you do use it?
Not really, not too much, occasionally.
Could you use your...
No, listen.
Appreciate it.
No, listen, my goal here by doing this was I said I would show you everything that I know as an osteopath. I don't want to edit things out and say, this isn't good because I don't use it. If I was going to do that, I wouldn't show you this. I have a colleague who graduated 2 years ahead of me in school on the same fellowship program. His whole day is counter strain. That's what he loves. He doesn't like cracking people. He never did. He's a very gentle sort of guy, big fellow, and his whole day is counter strain. So he might sit here and teach you and tell you this is a great technique. He's got a lot with it. So I need you to see it. I had stuff that was edited out for me because my teachers didn't like it. If they didn't like cranial, you weren't going to get it. In Philadelphia, you know, cranial was a bunch of nonsense. Cracking backs and muscle energy, that's what we did. Cracking skulls and taking names. Okay, so I don't want to do the editing for you. What I do want to give you is some annotation. I don't use it too much because I don't find it by itself to be too useful. But in counter strain, when we do a counter strain weekend, I use counter strain. But here I don't have much to do. Open, deviate, malocclusion. Doesn't make sense to me. I got a little bit of something on here. The real money will be, comes back next week, Steve, I feel the same. I felt a little bit better for 12 minutes, and I feel the same. Or I felt better, that really helped. Other questions?
Do you ever
Okay.
take his jaw for your range of motion with your hand? Or
Pardon me?
Do you ever take his jaw for your range of motion
Nope,
with your hand?
nope, I'll tell you why. Okay, again, we learned in school, we learned mechanics of the jaw in school, and we learned mechanics of the foot. And I have more than a few dentist friends and a few podiatrist friends. And what I realized is there's a reason why they go to 4 years of school just for the foot and 4 years of school just for the teeth. They know way more than what my teachers told me in a half-an-hour lecture about how it all works. So the jaw is much more complicated than it opens. We learned that if the jaw opens and it deviates to that side, the problem's on that side. And my dentist friend said, this is such a load of crap. Where did you ever learn that? I'm like, I learned it in school. You know? They're like, it's not so simple. Okay, my podiatrist friend, same thing. You know, we learned supination, pronation, eversion, inversion. And I had one of my friends sit me down. He says, you really want to see how the axes of the foot move? I'm like, yeah, I really want to see. And he helped me understand a lot more better. He just blew the socks off everything that I got again in the half-hour lecture of what we got in the school. So I don't think I can say, here's the test, there's the problem. What I can do that's not going to lie to me as a body worker is say, this muscle feels tight, that muscle doesn't feel tight. I can go back to some mechanics that I am comfortable with, cervical spine mechanics, skull mechanics. I use the tools that are before me. Okay, so that, and the last thing is, if I want to do something, no, stay there. If I want to do something to the alveolar processes, and it's an occasional technique for me, and it's because someone's complaining of pain after a dental visit. Question no one's asked me yet, but people do ask me, is do you recommend that they should get a cranial treatment before they're going to get dental work, or cranial treatment after they get dental work? In a perfect world, if money doesn't matter to them, sure. If money matters to them, which is most people, I don't recommend it. I don't recommend to do anything before you get anything else done. If you have a problem, let's do it. If you're worried about it, no problem. That's just me. Other people are going to tell them, but I think it's a sales pitch. Let's just do this, keep you absolutely well. There's no reason why you shouldn't be able to survive a bad day at the dentist. We've all had it. You have a rotten day and you get over it. You can either just do a quick survey around his teeth, and what I'm doing is I'm just taking with my thumb and my forefinger and going all the way around his chiclets and see if some area calls out to you, but I'm not doing that with a patient. If he says, you know, I had some work done here, my tooth is really sore, my face is hurting me, my eye hurts me, okay, let's do a little unwinding for this. And if I decide to unwind a tooth, you have any problems with any of these areas up here? Would you like a problem with one of those areas? Okay, open. So if he said to me, this area is bothering me, Steve, then I'm just going to pinch it between my fingers and I'm going to rotate, just like you would unwind a screw, one way or the other way. Not back and forth, just one way, indirect, take it the way it wants to go. I'm on the alveolar process. I'm not pulling on a tooth. We learned to do this test called the Matchbox test, and depending on what this test tells you, it tells you which side you're going to do. This Matchbox test is going to determine if they have a problem at the SS pivot. I got to give you the history, and I'm holding myself in check for my commentary. The spheno-squamous pivot, okay, which is right here. Okay, this is sphenoid. No, wait a minute. No, not that. That's another pivot. There's a point where this bone takes a little turn in its bevel, and they call it the SS pivot. And so this is a test to determine if there's restriction at that pivot, and then if you determine it's restricted on that side, you're going to do this technique. What I want to tell you is this is some sort of oral tradition that's come down, and I got zero way to verify that you have tension at the SS pivot, and I think they have zero way to actually verify that as well. But this is a technique if you want to get as deep as you can into a human mouth, short of putting them under anesthesia, and yank on something. This is a good technique for that. I've done it, you know, when I was in regular practice a few times a year, but it's really more of a patient who's really tolerant, a patient who thinks that they're not getting their money's worth unless they crawl out of the office, here's the technique to do for them. Okay? There's some benefit to knowing how to do this. When you want to say, I can't move anything, they got a stone head, is there something else I can do? But on the toughest cases that I've had, like the little children and whatnot I showed you, I've not done this. We're going to reach back behind this medial plate. You can get there in the mouth. In front of this is the greater palatine foramen. Okay, we're going to do this test, which doesn't make any sense to me, but I need to show you how I learned it. And you're going to do it on one side or another. The technique is going to be to reach back behind this, try and hook under a little bit, and pull forward, pull anterior. And it's really quite a wonderful, wonderful release. Not
The
really.
universal joint.
Not really. So here's the test. You're going to grab their skull between a frontal bone and zygoma. You're going to compress. Let me have somebody up here. Where's young Paul Ryan? Mike, come on up. Mike, come on up. I want to hurt Paul. I'll hurt Mike.
Hurt Mike.
Only hurt the ones you love. Get a real special feeling for you.
I'm not feeling the love.
Okay, so I said, why do they call it Matchbox? And Fred said, because of the old big matchboxes, the ones that maybe you light if you have gas stove with. So that's, you'd put that box between 4 points. 1, 2, 3, 4. Your MCP joints, okay, on the inside. So you're going to go on frontal bone and on zygoma. Compress and then torque. Okay, and when you do this compression and torque, you should determine like quadrants. 1, 2, 3, 4, which felt tighter to you. If you felt that it was tightest on one of these two quadrants up here, then look to the frontal bone for where that problem is. If you felt it was tightest down here, then that was supposed to indicate that they had restriction at the SS pivot, and therefore you would do this technique. So there's the story, and there you have it. Do I do it? No, never. I do it about 10 times a year whenever I'm teaching this exact thing. That's when I talk about it, because it's the history of the technique. The technique, can you give me the changer? Okay, it's going to be, oh, right, I can't do laser on this. There you go. So I'm going to be on the medial aspect of that perpendicular plate. Okay, that we're going to be able to reach inside his mouth. Okay, just another view where that arrow happens to be. I got lucky. These pictures were taken from a chiropractic book by a guy named Dr. Pick. And these are his photos. Mark Pick, yeah. Yeah, so he's got a lot of great dissections and whatnot.
The suture book?
Yes, yeah, it's a great book, and I buy books for the pictures. Now I don't have to buy books, you just steal it off of whatever you put on YouTube, Facebook, whatever, it's all mine. So we can go very far back in there. You're going to be right back, right next to the choana. If they have a problem with gagging, you're not doing this technique unless you've done every other thing in the world to them. If you haven't done much to them and you decide to go in and do this again, say goodbye, because you'll not see them again. Okay, it requires a lot of trust. As I said, a few times a year I would do this. I'd find somebody, their indication or the patient, quite honestly. You know, I'll indulge you if you're a little bit nutty. You really need to have a certain amount of pain. We can do that as part of your treatment. I used to have this old guy, old Italian fellow, and he was just relentless with me. At 80-some years old, better shape than I am right now for sure, but had a car accident, had some low back pain, and no matter what I did, really trying to help his problem, he's like, "You got it, that spot right here." And I'm like, you know, Mr. Albrisi, this is just not good. I understand it hurts. It's because your back is old. But that spot right there. I said, okay, is this the spot right here? And he'd go, ooh. Yeah, so I tortured him for about 1.5 years. I never made him better because his anatomy was permanently changed, and he really, really seemed to derive pleasure out of that. And after a while, so did I. So
we don't have that problem.
So I said, "Is this what you think you need for therapy? You know, you're gonna tell me?" And I would just drill in that spot. And he's like, "Oh, ooh, yeah." You know.
Is that codependent?
I You know what? I gotta tell you the rest. Right now, you're gonna get it. Did you ever meet someone who can't be insulted? If you ever met someone, you go, I hate you, and they're like, really? You know, they just can't be. This was that kind of guy. So when I want to leave the office and make an appointment, he'd always be disrespectful, come late, whatever. And I try to accommodate people. And then one day I just got sick of it. I'm like, you know what? He's not here again for his appointment. I told the receptionist, and she was hard as nails too. I said, I don't want. That's it. I'm done. I don't want to treat him. I don't even want the money. Just I don't want to treat him. And I only have one door in my office. So she says, he said he's right around the corner. Now I know he's going to catch me in the parking lot. So here I am, an adult, hiding in my own office, okay? And I'm not kidding you. I closed the shades, and I had a student with me, and the receptionist, she was tough as nails, man. We say South Philly's a tough area, so she was a very beautiful Italian girl and tough, didn't take anything from anybody. So I'm hiding in my office, because I want him to come and her to tell him I'm closed, and then I can go leave the office. So I'm hiding with the student, and we're just kind of giggling, and there's...
Oh,
and we're like this. I know you're in there. I know you're in there, Dr. Sonic. So I'm hiding, and finally the receptionist, she had enough of his crap. So she comes to the door, and she opens the door. She's a white girl, but she can do this thing, you know. She goes, what? He left. He goes, come on, I know he's in there. She goes, he left. and he said something else to her. And she said to him, this is a quote, she said, you are, without a doubt, the most annoying person I've ever met. And I know that's not the first time that's been told to you. What'd he say? Come on, honey, come on, honey. They had this interchange for like 5 minutes, 10 minutes.
How did you stop from laughing?
I was snorkeling in the back room with this student, and then finally he left, and I waited, you know, an appropriate amount of time until I was sure that his Oldsmobile Buick was around the corner, so I could get the hell out of my office. And I didn't treat him. So yeah, so he was a kind of guy, you know. You want to be tortured? Let's do it. Okay, so generally speaking, I'm not torturing people except for rare exception. And then sometimes I felt there was some benefit. Hey, look, I've tried everything else. This still isn't working. You still have your complaint. This is going to be really uncomfortable for you. And that's always my words, by the way, because I'm not going to say it's going to be painful. I'm going to say this is going to be really uncomfortable. It's going to be emotionally uncomfortable when I stick my finger that far back, and it's going to be painful. So this test, I've never done it. I've learned about it, pretended that I knew what I was feeling when I did it with Fred, because I just don't get it. I can decide that one side feels tighter than another. I don't have a problem with that. I have a problem with saying that equals the part where the sphenoid bone changes pivot. That I can't get there from here. So the technique is this. Let's see if I can get another slide after that. This will be the worst thing we'll do today. Actually, this will be the worst thing all weekend. It'll be this.
Thanks.
Bilateral? Or you?
No, I'm doing one. I'm just doing one side.
Next
Yeah.
10 minutes out of
Right.
Oh, because it's
You're just demoing it, right? We're not
I'm
actually
picking
doing
one
it.
side and doing it. I don't see a reason to do both. So here's the instructions. I think I wrote the instructions on one of the slides. Here's the instructions here. So if I'm doing this side, okay, what I'm going to do is I'm going to ask him to open his jaw, and I'm going to ask him to deviate toward the side I'm working on. Okay. Watch here, and then you can read that. If I want to work on this side, his jaw's coming over here to make space. If I'm working on that side, his jaw's going on the other side to make space. Whichever side I'm going to work on, I'm going to take the ear, grab the ear from the inside, and I'm just going to go lateral. I'm trying to create as much space as I can to get my finger all the way back. I don't think I should put another different photo up here. This is the Greater Palatine.
2 out of 3.
Okay. There's the Greater Palatine frame in there. I'm going all the way back. This is the choana. That's the open space. So you can go to where that Greater Palatine foramen was. So you're going to open your jaw that side. If I go to this side here, if I go back in his mouth, here's the crus, here's the greater palatine foramen. That foramen is bounded posteriorly by the medial and lateral plates of the pterygoid. So if I go behind it, I'm going to hook up. You're not going to hook, you're not going to get under it, you're just going to put pressure on the bump. Pull the ear very far laterally and pull up to the ceiling with your finger. Mike is a really tolerant individual.
How's that feel like?
Oh, there's a lot of pressure there. These are not light techniques. There's a lot of pressure there.
No.
And the ear thing too.
Somebody else wants to lay on the table, I'll do it.
Pressure on the bump. So what's the benefit here?
The benefit is to the benefit is to loosen the sphenoid bone from the inside.
You're not
You're
going to
trying
mess
to-
him up just doing one side like
Yeah, he's my friend though.
Somebody
Somebody did this to me. I said to somebody the other day, I was at a conference where I learned this with Fred. We were, I think, a group of 8 people, and there was one person that nobody wanted to work with. So when it got to this technique, everyone else like partnered up immediately. They found a partner, except for, me. So I worked with one person who grabbed inside my skull and was completely unsensitive and just started yanking. And because I was a guy and she's a girl, I didn't want to, I'm a guy, I'm tough, and I left with like a 2-day headache from her doing that to me. So you might hurt each other with it, or you might learn it for the first time on a patient, so that's your choices. Okay? So it's very tolerable, it's very doable. I'm doing a lot of this at the end of treatment. My treatment, I want to be pleasant. The last couple of minutes should be pleasant. So all the digging, anything that I've been pulling out of people's faces with my hand all the way down their oral cavity, once that's done, that's when I decide to do things like balance the ethmoid, a little bit of playing around the nasion and some of these techniques. And so commonly I'm evaluating the ethmoid at the end. This bone, our theory continues that if this is the sphenobasilar junction here, it's rising up, we call that flexion. The rest of our axis is that the greater wing is going down to the feet, and the ethmoid bone is turning up. I gave you that little morphological thing that is in osteopathy cranial field, that the upturn, the nose is turning up. I'm not into the morphology. But this motion, the ethmoid bone, can we contact it directly? You might say to yourself, and Paige, you would answer yourself, no, you can't contact it directly, because it's behind the frontal bone, it's above the vomer. So here's nasion, here's glabella. The axis of rotation is in the middle. Please keep in mind, because somebody asked me this yesterday. I think it was yesterday, it would have to be, right? Yeah, yesterday. About where's the axis of rotation here and there. And the books have different things. You can tell that the candle's getting really, really low now. So these axes of rotation, different. Don't start on me. Don't start on me. So people talk about where these axes are. Just realize this is just theory. I agree with the theory that I think these things are moving in the way that people say they're moving. But whether that axis was actually here, through there, you just can't get me to there that you actually know where that is. But let's agree that it's a single bone and it's doing this kind of motion. People write about, because it has these lateral masses, that there's a component of external rotation, like the frontal bone, coming out and rotating. I don't know a way that I can palpate this. So whether that's true or not, at least it's not an experience that I'm able to relate with you. What I can relate with you is this front to back motion behind the metopic suture, and it's very palpable. Not only is it palpable, it's just relaxing. It falls under the category of nice things to do for a person. So I'll do this balancing at the end of treatment, and with the size of my fingers, they're just going to be right next to each other. One on glabella, one on nasion. And I'm taking them through flexion, extension, and I follow them with the rhythm. For my end treatment, if I do things that follow your rhythm, it's going to be pleasant. You're going to perceive it as pleasant, and I'll try and take it a little bit further each time. Okay, so this is the ethmoid inflection. If you think of the upturned nose. So in flexion, I'm just going a little bit of pressure down and pressure off. I'm not coming off of the skin. I'm showing this here to be clear about what's flexion and showing what's extension, but I'm not coming off the skin. So I'm going to set up this rhythm that you have, that you already have, I'm going to follow it. And that's going to start to make you relax. My goal is that half the adults will be asleep at the end of treatment. And that process I start in the last few minutes. And half of them I can put to sleep in a few minutes. Does that mean something more occurred for them? No, it doesn't. Just on a very conscious level, they leave relaxed. They also, when you put people into a parasympathetic state or like a light trance, it kind of distorts time for them. I've one argument that I've had to fight my whole practice is the amount of time that I spend. The amount of money that I charge versus the amount of time that I spend. I wish you would spend more time with me. Well, then marry me. We'll spend lots of time together. Okay? Or actually, ask my wife. We don't spend much time together, so I'm on the road. But I have a certain amount of time, and if I can put you into a light trance, it distorts it for you. And if you wake up like this, and the eyes are injected, we call it injected, the conjunctiva, when it's all red, that means you went into a parasympathetic state. It gives you that sensation of feeling rested a little bit, even though you haven't really. You start to shut down. Anybody been hypnotized before? You ever been hypnotized? Yeah, you snap out from that and then you feel like you just had some kind of rest. It's the same illusion. And it is an illusion, but if I can give you that illusion, I'll do it. For the children, I give no illusion. I thrust myself upon them, do my technique, they're crying, carrying on, I try and calm them down, and then I punt them out the door, okay? Because their parents are happy with me anyway. With you, I sort of have to try a little bit better job to make you happy, so I do it. So I walk through this balancing technique, it's pretty fun. I'm gonna go through a couple things and we can do them all together here. The next thing I do is I do a nasal distraction. And again, with the size of my fingers, I don't do work in the nasal bones, even if you've had them fractured. I haven't found that it's been beneficial for me to do it, except for this one thing. And I do it at the end of treatment because it's very nice, it's very relaxing. And I'm going to separate, it's the slightest separation, it's not hard at all. I'm going to separate my fingers and then I'm going to do a seesaw with the separation. So if you picture this, I'm going to separate my fingers and then I'm just going to carry them, okay, a little bit faster than the rhythm, and then I'm going to start to slow it down. I'm going to start faster and I'm going to slow down. And that's a theme that's going to continue. And this is to put you into a parasympathetic state. Is it curative for any particular thing? No. This is all my illusion at the end of the game. Okay, to make you feel a little bit more relested, which means, it's a new word, relested, that means relaxed plus rested. Okay?
Chillax.
Which actually could be, it could be relaxed plus arrested. We can go to a dark spot with this. So, let's see what else I'm going to do. Okay, so what I'm trying to show here is I'm separating and then I'm doing a little bit of a seesaw action. So it looks like this. So whoever volunteers now, I promise this is pleasant. I promise you a good time. And there he is, right there. There he is. Stay down. May I have?
You're not on the team.
Slide down a little bit.
I've been eating donuts.
I might as well have the donut because I'll be accused of it anyway. You use whatever fingers you want. I'm very comfortable using my ring finger and my middle finger. Again, fingers don't matter. I've just got used to doing this. So this is flexion, this is extension. From here, even though this ethmoid bone is behind the frontal bone, you can feel this. And if you want to push and be hard about it, you can find some motion here. So the first thing I do is I move a little bit without rhythm, and then I follow the rhythm. I mean, there's really nothing to see. How's that feel? Huh? Relaxing? I think you have no choice but to give an answer like that. So I think it's a biased opinion. I mean, I believe you. But I think it's biased opinion. Slide down a little bit. I like my elbows on the table. I always like my elbows on the table working. I see some people around the room, if you're doing things like this, I don't know how you relax like that if you're holding your shoulders up. Okay, orbicularis oculi release. So what I do for this is I take all my fingers and I put as many as I can just around the orbit, not on the eyeball, around the orbit, and I just do it as an indirect fascial release. And I've done it as a quid pro quo thing, which I don't usually do, and that is you're having some pain around here, you have actual pain around your eye, let's do something around that area. I still am going to look around their body and see where I think somewhere else needs to be treated, but for doing an eye thing, it feels very pleasant. At first, people are a little weaky with it, with you putting fingers near their eyeball. And I do that release, it's going to be a quick release, 15 seconds, 20 seconds. When I'm doing that, then I'm always following it by just a release of the globe. I was told, tell people to take their contacts out before they do this, and honestly, I never do. I just do the technique. If your contact moves around or whatever, you can figure out how to get it back. I haven't told people to take the contacts out, because that's going to be another 3 minutes of my life I'll never get back with them getting up, going to the bathroom, whatever. And some of the cautions that I've been given just haven't materialized for me, because I do this technique enough. It's not part of a routine that I'm going to do orbicularis oculi in the globe. It's not part of my routine, but often enough I feel there's tension around the face. Let me just do this. This I'm going to take, again, use your lucky finger, okay? This is my lucky one. So I put a finger on the eyeball. It's, I don't know, it's grams of pressure. I'm obviously not trying to dislodge the eyeball. That would be bad. And then when you do that, you put a little bit of pressure on the eyeball, it'll go somewhere. I don't know where it's going, but it's going to go somewhere. It's going to go towards one of the recti muscles, and it might take a little turn. And I just follow it. And I find that these two techniques, when people are complaining of eye pain, either because they have a problem with their occipitalis muscle pulling on the saphenous nervosus, pulling on the frontal muscle, or something more complicated, a little bit of release here, it feels quite pleasant. Okay? Ray, since you are in position.
It's also going to lower their tone because the eyeball is the end of the nerve.
It is. The eyeball is brain tissue. Actually. So I'm going to get as many fingers as I can around here. 4 or 5. I'm leaning on the table for this. If you're not leaning on the table, then you're going to start putting abnormal pressure on their eye. Fall into the slide over just a little bit. That's good. Okay. So if you're good. Pressure here. I got 4 fingers on them, and I'm just going to make a circle, whichever way is easier. I'm going, the way I'm looking at them, I'm going clockwise. At first it's me pushing, and then I feel the tissue relaxing on its own. I might follow it a little bit more, but none of it's going to be extreme tension. I feel I got another, like a second release. That's it, I'm done. Now, I'm going to put an ice pick in his eyeball. See, he doesn't listen to me anyway. I think he's asleep, so that's the perfect candidate here. So I'm going to hold.
I'm hypnotized.
There we go. So I'm going to hold the side of his face so that it's easier for me to control my pressure on his eyeball. All I'm doing is letting him close his eyes and putting a little bit of pressure down. When I do that, I don't know if he is, but it's like his eye is looking up. It's just going, it's rolling upwards and a little bit towards laterally. It'll feel relaxing, or it'll feel like nothing. Who aren't you going to do it to somebody? If their eyes are irritated, if they have allergies, you're going to irritate it more.
What about like a retinal vein? Should you be concerned at all with anything like retinal vein occlusion or no?
If their doctor says, don't touch their eyeball, then don't touch their eyeball. But do I think you're going to cause any damage? No, not with the pressure I'm using. In this case, it is grams. And when I'm at this section, when I'm at this part of the treatment, I really want to blur those lines between when I'm touching and I'm not touching. So I want to do a couple of things, and each one I don't want to wake the baby. I want the baby to go to sleep. The baby also wants to go to sleep. Okay? Not magical points. It's just a bastardization of something else I was shown for another reason, and I found that seem to have this side effect, and so I just do this. What I put with my fingers is I just start 1, 2, 3, 4, easy to do, bilateral along the metopic suture, and I start just at the nasion. And I do what my mom used to do for me when I went to sleep. Itsy bitsy spider crawled up the water spout. Down came the rain and washed the spider out. I won't do any more of it. So what I do is I'm going to hold the head here. I'm going to put my hands here, and I'm going to start touching, and I'm going to start setting up a rhythm. And I'm going to go. Let me do it first. I'll do it, and I'll explain it. Okay.
You used to play the recorder?
Only at Renfish.
Is that where this is coming from, really?
We're ignoring him. We're ignoring him.
You going, I can't tell, are you going up and down, or are you just going up or going down?
Or 1, 2, 3, 4.
I'm going to tell you in a minute.
Yes, sir.
Answer's coming. Me too. It's good for both of us. Don't tell Ray. Our little secret.
Tell me all about it.
Okay, now here's what I did. I learned this as part of another technique for another reason, and what I found out was when we were doing these things, we sort of had a side effect of people just waking up like, okay, and I said, let me explore more of that. Because you put people in a parasympathetic state really quickly, and it's quite pleasant. It's pleasant or it's nothing. You know, it's why you're dancing on my head. Okay, but half the people, you've already got them, you've released a lot of tension, you're taking them to a place they want to go. Separate little background piece of information, you can relax. I took a weekend with the American Society for Clinical Hypnosis, and we did a weekend of inductions. And when we studied inductions and putting people into a state of trance, what I learned, or I took home from the whole weekend, is trance isn't something that's like, now you're going to go, you know, you're in this crazy state and now you're in a normal state. No, no. Your body goes into these complete consciousness and little states of trance all the time throughout the day. Trance is just a focused state of awareness. That's all it is. There's different levels of that. When someone comes in to see you for treatment, they're already halfway somewhere because they're focused on what you're telling them. So if you're telling them, gee, you're never going to walk again, it's really potent. I don't say, gee, you're going to be fine, because I don't want to be responsible for that. So I'm careful about what I say, because what you say already has another level of importance. They're bringing you their physical problems, and they're open. They're not taking in their whole world. They're now calming down. What you're saying is very, very important. Okay, so that's one thing you need to understand first. Second, I'm doing this in a pleasant, non-threatening way. It's easy. I've done some other little distraction and other game playing, all pleasant. And I told her no more discomfort for the rest of this treatment. So I'm going to set up something that's undeniable for her, okay? And I'm going to... Is that annoying you?
Not yet.
But it's going to get in there, right?
Say
Eventually.
yes, Ray. Just say yes.
Okay?
Yes.
It's undeniable. You start following rhythms, good ones and bad ones. So what I give her is I give her something that's not terrible. And then I go slower and softer. Half the adults, that's the sound we hear. These aren't magical spots. They're easy for me to do. I put my elbows here, put my hands here, and I go 2, 4, 6, 2, 4, 6, 2, 4, 6, 2, 4, 6, 2, 4, 2. I'm done. I try to lengthen that. There, even if she consciously knows what I'm doing, she's following. It's pleasant. I'm taking her with little cookies where she wants to go. Go to sleep. Okay? And then so she waits for the last one that doesn't come. And if she doesn't fall asleep, it's still relaxing. Little experiment to self. Try this with your patients. And look at them first. Look at them when they're done. If they open up their eyes and their eyes are all red, what it tells you is you put them really quickly into a parasympathetic state. And I'm taking her to where she wants to go. You can't hypnotize somebody. John, you're now relaxed. Go rob the bank, bring that cash back here, okay? What you can say is, John, you're really relaxed. Dance around like a silly chicken. Because most of us have silly chicken hiding in there. And we don't mind it under the right circumstances. If John goes and robs the bank, he was a bank robber anyway. Okay, you can't make people do things that are deeply objectionable to themselves.
That's not
So, pardon me?
5 to 10% of the population can.
Rob the bank?
Yeah.
You and I are probably part of that 5 to 10%, I think. But anyway, so you're taking her somewhere pleasant that she wants to go, she wants to go. So this is what I'm doing with all my adult patients. I try to get that moment where I can just put them out, and then I give them a little 30 seconds of that. That's all you're going to get, and I'll wake them up. I used to use that time to go over and write my notes.